It's our final session on photoreceptors, structure and function. And I want to ask the first speaker to share his screen. It's Michael Pircher from Medical University of Vienna, talking about extended field of view imaging of human photoreceptors and RPE cells.
Hello, everyone. Can you hear me?
Yep.
Good. I will just share the screen. Can you see the screen?
Yes.
All right, perfect. So thank you very much for the opportunity to talk about our recent research we're doing on adaptive optics imaging of the human retina. So I'm talking mainly about the publication that has been published just very recently in Biomedical Optics Express. All right. Before I start, I want to acknowledge the people from my center and our collaboration partners from the Department of Ophthalmology, Imagine Eyes, and of course I want to acknowledge the financial assistance. Without them, this research would not have been possible. So what is the motivation of the extension of the field of view in adaptive optics imaging? So we know that adaptive optics can generate really nice images, and these are depth integrated OCT images of the fovea centralis. So with this high resolution, we can resolve really the central foveal cones that are very, very tiny. And if you go to temporal retina, we can see here at 8 degrees temporal from the fovea, we start to see here in colored in red the cone photoreceptors, and these photoreceptors are surrounded by the rod photoreceptors. So we see these extremely nice details. However, one limitation of this technique is the very limited field of view. You can see it here that we have a field of view of 0.8 degrees, roughly to 2 degrees. So what is the reason for that? Or let's say, what is the motivation? We want to see similar like the ophthalmologist is used to, like this fundus photograph of 45 degrees. We want to see a large portion of the retina with this high detail, and AO itself can only provide this very, very tiny field of view. So the question is, how can we extend that while maintaining the high resolution? Obviously, you can extend it by sacrificing the resolution, but is it also possible by maintaining a large portion of this high resolution? So what are the limiting factors for imaging with adaptive optics? One is the isoplanetic angle in the eye. So meaning that the aberrations that we're correcting for with adaptive optics are not constant over the field of view. This is a nice work from Batchgood, measured at 500 nanometer with a 6 millimeter pupil, and here are the different subjects in the end, and the evaluated isoplanetic patch where the aberrations can be assumed constant. We can see that here I have one subject where the isoplanetic patch extends over roughly 2 degrees. However, for the majority of subjects here, we can have a 0.5 to 1 time degree. Another problem is, of course, the aberrations of the instrument itself. So many adaptive optics instruments are based on mirrors, on spherical mirrors, and they will introduce spherical aberrations depending on the scanning angle that you apply over these mirrors. So what we have done here in order to address these challenges, we wanted to extend the field of view, and thereby we relied on our previously published lens-based AO system, which is here a short sketch, just going roughly into detail how this system works. So it's entirely based, instead of mirror telescopes, we have lens-based telescopes. So here comes from the light source, fiber beam splitter for the OCT imaging, and the light enters here the sample arm. Then we have the telescopes with the image, the pupil plane, to the deformer mirror, also to the scanners, and then to the pupil plane of the eye. On the way back, so the light is back scattered from the retina, goes over the same path again, and is detected here by a spectrometer for OCT imaging, and part of the imaging light here is diverted to the Jacque Duncan wavefront sensor for wavefront sensing. So what are the key features, or the 3 key features for our system? First of all, we're using a cross-polarized light for the wavefront sensing. So you can see that we have here introduced polarization optics. So here's one polarizer, and this polarizer is orthogonal to the first polarizer. So only a cross-polarized light will enter here the beam path of the Jacque Duncan, and this is also a polarizing beam splitter. Second important issue is that we have a triggered wavefront sensing. So normally you have a separate wavefront sensing running on its own loop and completely independent OCT recording. And here in our system, we make a connection in order to improve the AO performance. And finally, the third point is an optimized system alignment, which allows then to minimize the aberrations introduced by the system itself. Just a few words about the system parameters. So we have a standard OCT system, I would say, operating at 250 kilohertz A-scan rate. The light source operating 840 nanometer with a 50 nanometer bandwidth. This results in an XL resolution tissue of about 4.5 microns. Yeah, I want to point out here that the usable pupil diameter that we have this system is 7 millimeters, so we should have a theoretical transfer solution if we're able to really correct for all the aberrations of 2.3 microns, so we should be able to resolve the foveal cones as well as the rod. The field of view, and this is extended compared to what I've showed you before. This is about 4 times 4 degree. The recording time of one OCT volume is 2.5 seconds, and we have a power to the eye of 650 microwatts and a system sensitivity of 86 dB. So why are we using the cross-polarized light? Why is this working in principle? So for that, I want to show you here some polarization sensitive images. So this has been done with a polarization sensitive OCT setup. And we can nicely see in the phase retardation that most of the interior layers do not alter the polarization state of the light. So this is indicated here in this nice blue color. However, we see in the image that here the posterior layer, the RPE here generates a random distribution of retardation values. The same can be also seen here in the so-called optic axis orientation. And this randomness of this RPE layer, this is very specific to the RPE layers coming from the melanin granules of the pigmented granules of the contained in the RPE. This gives you a complete depolarization of the light. So what happens if we have a linear polarized light incident onto the retina? So meaning that all the interior layers here don't show any change of this linear polarization state. However, we will get a cross-polarized light here only from the RPE. In that sense, by using this polarized technique, we can have a depth-gated wavefront sensing. So we get the light from for the wavefront sensor originates mainly here from the RPE. And with that, we can optimize, so to say, the wavefront of the light coming directly from the RPE. We do not have any other influences, for example, coming from the photoreceptors, but more importantly, also influences here from the nerve fiber layer, which you can see here on the left-hand side image here, also be quite reflective. So the second point I brought up was the triggered wavefront sensing. So if you don't have any triggering, what happens if you scan across a larger field of view? I told you before that we had this isoplanetic patch, but if we are scanning over a larger area than the isoplanetic patch, then we have variations over the field of view in terms of our aberrations. So if we don't synchronize that with our scanning, this means that we have the Jacque-Hartmann exposure here, catching up the aberrations from this field of view. Then we put in the AO corrections. In the next iteration, we're catching up slightly different aberrations here from the scanning pattern and provide the aberrations here and so on and so on. And what we observed then is that we have really varying wavefront measurements and therefore as only a suboptimal wavefront correction of the aberrations. If we do implement the triggering, then we can set arbitrarily, basically, the Jacque-Hartmann exposure time to the field, and we can keep it completely stable. So we can, for example, set it here at the central part of our scanning pattern, and this will not change with the loop of the adaptive optics, and therefore we have extremely stable wavefront measurements and an improved wavefront correction for this larger field of view. Yeah, and finally, we optimize the system alignment. So we know that tip and tilt of the lenses in the system will introduce aberrations. It always sounds nice if you design such a system in Cmax, for example, and you end up in minimal aberrations over the entire system. However, the practical realization is the second point. So we really took a lot of care to come up with an alignment procedure in order to perfectly align the individual telescopes and in order to minimize the overall system aberrations. And for that, we directly use the Jacque Duncan wavefront sensor in order to minimize the aberrations of the imaging beam towards the system. So what are the imaging results? So this is a fundus photo of 30 degrees, and we have roughly 4 times 4-degree field of view. And if you zoom in, we can start here to see here the individual cone photoreceptors. So the resolution of the screen here is not sufficient in order to show all the details. So we need to zoom in, so that you can really appreciate that we can resolve the individual cone photoreceptors as close as 0.2 degrees to the fovea. So the central part is obscured, mainly because of the sampling. We should not forget that we have here 4 times 4 degree, or 1.2 millimeter times 1.2 millimeter field of view, and we have 750 times 750 pixels. So really in the central part of the fovea, we're running out simply of sampling points, and also additional motion artifacts will influence our visibility of the cone photoreceptor mosaic. So since we're doing OCT, we have, of course, access to the entire 3D volume. So this is a linear single piece scan on a linear scale. So you start to see here the individual cone photoreceptors in the outer segment junction, as well as in the cost layer. So here the different layers better visible by averaging over a couple of B scans. And we can see here nicely the RPE and also this very faint layer here of the chorocapillaries. If you look very closely, you see that actually there are 2 layers of high reflectivity containing of the RPE. So this is the on-fast projection I showed you before. And if you zoom in to the B scan, here a little bit more, then we can see here the individual reflection coming from a single cone photoreceptor. And if you look here, we have the foveal reflex, and we have also here the elevation. So we are very, very close to the fovea centralis. Let's move through the different layers. So this is the fast projection of the inner outer segments, just only segmented over roughly this line here. And if you zoom in here in the fovea centralis, we start to see in the periphery the individual cone photoreceptors. Here in the center, really the central part, it's a little bit less clear. Go deeper to the cone outer segment tips. You can also zoom in here, and here at the periphery start to see nicely the cone photoreceptors. And if we go deeper, then we start to see a different pattern corresponding here to the RPE cone mosaic, the RPE cell mosaic. And if you do here a Fourier transformation over this area, this pattern, then we start to see Yellard's ring with a different spatial frequency, way lower spatial frequency than from the cone photoreceptors, indicating the spatial frequency of the RPE cells. So we have done that for several subjects, and then you can average around a circle on this this image of the Fourier transformation in order to get this plot here, and we see here the peak of the circle indicating the spatial frequency or the row-to-row spacing of the RPE cell mosaic, and with that we can quantify that, and we found the row-to-row spacing of roughly 14 micrometer, which corresponds well to what is expected with histology. So we can also focus on the periphery. So this is an imaging done at 5 degrees eccentricity nasal from the fovea. We start to see this thick nerve fiber layer, and here we can see the individual cone photoreceptors. Here we need to take a closer look at the individual labeling. So of the layers, we have here the external limiting membrane in outer segments, and this faint line here, this corresponds to the cone outer segment tips because of the large spacing of the cone outer segment tips. This appears in the averaged B scan more fainter than the other layers. Then directly beneath that or posterior to that, we have the rod outer segment tips, and then we have here again these 2 layers of the RPE, and yeah, then this faint layer posterior to the RP corresponding to the chorocapillaries. So what are the imaging results here? If we look at if you segment from the cost layer, we see the individual cone photoreceptors. We have some residual aberrations introduced by the eye, by variation of the isoplanetary patch. That's why here in this corner, for example, the cone photoreceptor mosaic is not as clear as in the rest of the image. We go zoom in here, we can nicely see the individual cone photoreceptors. If we go to the rust layer, then we start to see a completely different pattern. We zoom in, yeah, we see the signal coming from the rods, individual rods, and although we are not able to resolve individual rod photoreceptors over the entire image at some locations, we do see the separation. And these dark dots here, they correspond to the location of the cone photoreceptors. And if you go deeper, we start to see a different mosaic. Probably I can switch forth and back so that it's clear that this is a different cell mosaic that we see, a different regular structure corresponding to the RPE. And we zoom in, we start to see here this regular mosaic coming from the RPE cells that I've shown you before. We go further deeper, so we get to this additional layer, which does not show this RPE cell mosaic, and that we believe corresponds probably to the posterior end of the RPE cells or to Bruch's membrane. And if you go further deeper, then we are here in the chorecapillaris, and yeah, you start to see some vascular pattern. You can combine the information, the depth information, and color code it. So here, in this image, the cone photoreceptors are encoded in red, while the rust signal from the rod outer segment tips are encoded in green. And if we zoom in, we nicely see that these gaps in the rust mosaic is filled here by the individual cone photoreceptors. So with a large field of view image, we can, of course, stitch larger areas of the retina. So these are 1, 2, 3, 4, 5, 6, 7 data sets recorded to span a larger field of view. And with a different segmentation, we can provide then a nice map of the cone outer segment tips here of this large field of view, but also of the RPE cell mosaic. And if we generate then the averaged OCT V scans, looks very, very familiar already to the standard OCT images. However, we can, of course, zoom in into every position in order to get this high resolution. And I want to point out here nicely the different labeling of the layers. So if we start here from the fovea with the inner outer segments in the cost layer, and we follow that to the periphery, we start to see that here the cone outer segment tips, it's getting weaker and weaker towards the optic disc. And on the other hand, if we start here from the fovea centralis, we do not see any signal from the rods because this is the rod-free zone. But if we start getting more to the periphery, start to see here this signal coming from the rust outer segment tips, which shows this characteristic pattern. And then we have here these two layers corresponding to the RPE and the continuous layer of the chorecapillaris. All right, so what are the remaining issues of this instrument? So one, motion artifacts. This is a severe problem, also for visualizing finer details like foveal cones, for example. For that, we need to go for faster imaging speeds, which can be realized either by dual spectrometer or quadruple spectrometer by what was realized with Don Miller's group, or to go to swept sources that provide imaging speeds of 1 megahertz or higher. We also need to address the residual field aberrations. So you have seen it that at some locations we do not achieve the highest image quality that we want to achieve. For that, we need to implement the field correction, which we have demonstrated for AO-SLO using a second deformer mirror and doing multi-conjugated adaptive optics. However, the concepts that we had for the AO-SLO is not directly transferable to the OCT imaging simply because of the slower imaging speed. And yeah, finally, we can also do contrast enhancement via averaging, which has also been done by or demonstrated by Don Miller's group in order to even better visualize the individual cellular structures. I have to point out that all the images I've shown you here were retrieved from a single volume scan, and apart from the stitching, of course, but the RPE mosaic can be visualized to some extent with a single volume scan of the OCT. Okay, then let me conclude. So the field of view, I think, can be extended in scanning adaptive optics OCT. And I could show you the cone photoreceptors, so the rod mosaic and the RP cells that can be visualized in a single volume scan. And the field of view can then be further increased in a reasonable time, I would say, with a 4x4 degree field of view in order to get even larger field of views. And in that respect, we are approaching in the end the field of view that is very, very familiar with a standard OCT. Okay, thank you very much. And I'm open to any questions.
So thanks very much, Michael, for this nice talk. I don't see any questions in the question and answer section. I had a little question. When you were showing the RPE images in the fovea, it seemed that we had a better view of the RPE just beneath the fovea and less further out. Is that due to the depth, or what would that be due to?
I think this can be attributed also to the isoplanetic patch in the end. So for this scan, we need to get a better resolution also in the periphery. This is not that problematic if we go in the periphery itself. So if we image directly at 4 degrees or 5 degrees, we did not notice that. But in the fovea, it seems that in the central part, you need to have very good resolution in order to achieve to see the RPE mosaic.
Okay, thanks. If there's no further questions, in the interest of time, I think we'll move on to the next speaker.
Okay, maybe I can ask before I start. I can ask Michael one more question. So
Good idea. Yeah.
Beautiful RPE cells. I was wondering how far he can push it to get more quality on RPE. So what is the main limitation in your system to get really like smooth delineation of hexagonal shapes?
I mean, the two things. So one is if you go to a smaller field of view, then of course you get also better contrast of the RPE cells, simply because the adaptive optics is even better than for the large field of view. If you go for a larger field of view, you have, of course, the mix and drawbacks. And the second part is that you can do averaging, what has been demonstrated also by Don Miller's group, in order to get even higher contrast of the cells.
Just,
averaging comes at the cost
question.
of time,
Sorry.
of course, of recording time.
In the chat, there was a question from Austin. How many pixels across your 4 degree field of view?
750 times 750.
Okay.
Okay, thanks. So we'll move to Maciej's talk, which is on full field OCT.
Okay, thank you very much, Kate. So I'm going to continue a little bit the technology development in OCT. So welcome from Warsaw. So actually our work is concentrates on further development of OCT methodology. And as you know, OCT can cover really a broad range of applications and scales of imaging. So this is just a demonstration that we can go from the macro level of entire organs up to subcellular level. But really the key application is ophthalmology, and we went a long way in the development of OCT. So you can see here the first data from Fourier domain OCT, retinal imaging that we did in 2001. So it was quite poor quality, and then went through all these phases with a high quality cross-sectional imaging, angiography, Doppler, and also anterior segment imaging, and to improve the quality a lot. But still we are not perfectly happy with the current technology that we have. And when we look at the most beautiful cross-sectional OCT images, we can find out that there is still lack of detail when we go and zoom it up to the scale of single cells. So when you compare it to histology, which is still a gold standard in many biological or medical studies, we are still missing in OCT these details to really differentiate cellular structure inside the retina. So, of course, one way to go is adaptive optics and combining it with OCT. We could hear it in the last great talk of Michael. And there's a lot of fantastic developments there. So one of examples is this paper by Don Miller, with massive averaging and very complex high-speed system. They could get really very beautiful reconstruction of ganglion cell somas and nerve fiber layers. They could even see microglia on the top of the retina. And the same was done by Dunhammer, also a very complex system, also long time of measurement. So that proves that we can really see very nicely details of the retinal cellular structure based only on the scattering. And also RPE cells are visible here. And then also it was a work from Robert Zawadzki group, and they helped a little bit to average the signals by adding extra dither to deformable mirror to see better cross-sectional images of photoreceptors in animals. And there is also another work, or a couple of groups are developing these systems for computational aberration corrections, because in eye imaging, in the retinal imaging, we will be always basing on natural optics of human eye. So to correct it, either we have to use adaptive optics, hardware adaptive optics system, or software solutions. And the software solutions seems to be very efficient and very practical, because once we perform the measurement, we can just do all the processing in a computer after the measurement. So we have access to this data all the time, and we can use many different ways or many different approximations to reduce aberrations. And another interesting work is from Hillmann, from Lubeck group. They used quite a simple system in contrast to the techniques that we just I just showed before. So in this case, we have really a very small amount of optics, and there's only very high speed camera here. And with these systems, they got also very nice reconstructions, and with the computational aberration corrections, they could see photoreceptors. So go down to cellular level. And finally, there is the longest actually technique that is present in OCT field, which comes from Paris. So it was developed long time ago, even before 2003. So it's full field OCT. That in the first demonstrations from in vitro eye imaging, it demonstrated really superior quality comparable to regular microscopy. So now this technique is converted to in vivo systems, and it gives very beautiful reconstructions. So it's a little bit complex system that combines time domain and Fourier domain OCT both together. So the Fourier domain OCT is used mostly for preview mode, and they can get from the time domain full field OCT excellent reconstructions in en face planes. So and recently, so we could hear it from Pedro Maciej that they are improving constantly the system, and they got this excellent data on a large field imaging of photoreceptors. So we have actually three methods that are complement to each other. So each of them has very nice advantages, but also they have disadvantages. So for full field OCT, for Fourier domain full field OCT, there is still a crosstalk noise, so we can see this haze on the bottom of the retina, and actually is covering the entire retina. So coming from the multiple scattering of RPE and choroid. In AO scanning OCT with the massive averaging, it takes really long time to measure, so it's not really clinically practical. And in time domain full field OCT, it's also slow. It requires this complexity with extra OCT system for preview mode, and it is limited only to single plane. So it's not so easy to reconstruct, to get the three-dimensional reconstructions in high quality. So we have these three methods that complement to each other, and it's for the first glance we can just take the advantages of each of them, combine it, and get the ideal technique. But it's not true. It's impossible just to do like that. So you have to finally identify the component that will enable us to develop another technique that will bring all these elements together in one system without all these advantages, meaning that the system that we would like to develop must be simple in terms of optics, must be fast, and must give these all opportunities of numerical aberration corrections and get high quality on fast imaging. And actually we identified this element to be the spatially decorrelated scattering. So simply in most of OCT techniques, except full field time domain full field OCT, the light that scatters from the retina, it always somehow memorizes the phase dependence in all the beam. So each point that scatters back to the detector has some well-established relationship in phase to other points. And that causes a lot of problems creating this so-called crosstalk and speckles that cover our image, and we cannot really recognize all these details at the cellular level. So our idea is really to have so-called spatially decorrelated scattering, meaning that each scattering point will have a random phase in comparison to other scattering points that are coming from the object, and then we can avoid these effects of speckles and crosstalk. And actually, we are not playing with the light source itself, because this could be, of course, obtained by if we use the spatially incoherent light. But in this case, we have other drawbacks of using such light, like low power density, and also with spatially incoherent light, we cannot really penetrate very deep. So to get the volumetric reconstruction at once. So we must somehow control this spatial decorrelated scattering by emulating spatially incoherent light. And this can be done by applying the spatial phase modulation in the light that is used for OCT. And our approach is actually that we use phase masks to modulate the light and collect consecutive images or consecutive OCT signals, and then average it out or process it in some way. And actually, we even extended this idea to have a two-step approach that we can eliminate crosstalk first as one effect of multiple scattering, and then to reduce speckle pattern by another modulation of the phase of our light. So this is again the same, more or less the same idea, because for the crosstalk reduction, actually we have to use very high speed phase modulator, spatial phase modulator, but that will modulate the phase with low spatial frequencies. And for speckle reduction, we have to use a very high frequency spatial phase modulator, but this one is much slower, and we can collect consecutive volumes of OCT data for different configuration for different phase masks displayed on this SLI, on this phase modulator. And actually, for this high speed modulation, we use such a small membrane that can randomly, almost randomly deter phase with hundreds of kilohertz. So it's very high speed. But the standing waves that are created on this metal membrane are actually of relatively low frequency. And this is just a measurement of how this phase modulation looks like introduced by such membrane. So we can see that there are only a couple of periods of spatial frequencies that we can modulate with such membrane. When we use this membrane in front of the interferometer and perform OCT measurements, so we will see, for example, if we measure the test target, the reflecting test target, And now we will start to the focus beam here in the sample arm. We will see that the region that is modulated by this high-speed membrane is just losing contrast and signal. The fringe contrast, meaning that the OCT signal is much smaller and is decreasing. While the region that is not modulated, there is quite a big defocus, but still we can see OCT signal quite well. So, meaning that in this region we can really reduce the signals that are coming from long optical path delays, for example, multiply scattered light, and then avoid effects of crosstalk. And so we built a system that demonstrated this idea that was published in Optica. And first we used it to image phantom. So we built the special OCT phantom. It's three-dimensional phantom of scattering phantom consisting of two PDMS layers that are highly scattering, one of the top of another. And we imaged it with OCT, and this is what we got in the first measurement. So we see one cross section is corresponding to this view. So we can see these two layers. One is very thin, one is thicker. And we see the scattering. There is a lot of opacities, haze, and also speckles. Then when we apply, so the first modulation with the high-speed membrane, we can reduce the crosstalk, so the haze is gone. We can see nicely through the sample, but still we have a lot of speckles. And now when we use only a coherent summation, meaning that we modulate the phase with high frequency and average it out after the measurement, we can see that the speckles are gone, but we have a very low contrast here due to the crosstalk. And now when we apply both steps, we can see that we can clean image nicely, and we can see with the high contrast or details within the sample. So we use this first to skin imaging, and this is an example of skin imaging. So this is three-dimensional reconstruction. This method is very fast because we use this very high-speed CMOS camera. So to get one volume like that averaged already, it takes around 0.4 seconds. And then we move to eye imaging. This is skin here, but this is eye imaging. So we have a cross-sectional imaging of retina, and this is just zoomed region. So this is a classical OCT without any averaging. So this is scanning OCT with the high contrast of speckles. And then when we compare it to this full field, Fourier domain full field imaging with so-called stock, so this spatiotemporal optical manipulation, the manipulation of the face, we can see the improvement in the image quality. So here for the system without phase modulation, we have quite a big crosstalk, and the contrast is much less than in the image, cross-sectional image with the phase modulation, with the control of the spatial coherence. So here we can see nicely all the details in cross-sectional image. We have also nice access to choroid. So when we go through different layers, so these are just cross sections along lines marked here. We can see that in NFL we see nerve the fibers. Then we go to plexuses to see the vasculature here, and then going to RPE, we can see a little bit the photoreceptors here, but still this was not modified, I mean, not corrected by numerical aberration correction. And then we can go penetrate quite nicely to choroid. So when you compare to the method that is not controlling the phase modulation, the contrast is much higher. And then we applied also this numerical correction of aberrations, and this is the comparison. These first images were done on a lens tissue. just to demonstrate how we can improve the contrast. So without the phase modulation, we can see that the contrast is quite weak, and the aberration correction works here well. But then with the phase modulation, we can additionally improve the contrast here. And also, this is the retinal image. The half of this image, half of this image was imaged with this deformable membrane, with this high-speed deformable membrane. So the phase modulation, and half of it was not applied. So we can see that the aberration correction works much better for the region that was modulated, and where we applied this spatial coherence control. And this is the result before corrections and after corrections. And then we also used, these are very preliminary results, approach that we could hear yesterday in Michel Atlanstock and Leo Puyo. So we can, for this data that we are collecting, we can also apply the laser Doppler holographic technique, so to analyze the flows and separate flows by different bandwidths. And these are our first results that we got from the retinas. So we can differentiate between retinal microcapillaries, and we can see also some flow from choroid. And then we moved to demonstrate this technology. We moved also to corneal imaging. So this is example of the anterior cornea part. So we have here epithelial cells visible in our images. We can go a little bit deeper to stroma to see nerves and the stromal structure. We can also image endothelial cells. So this is just comparison to the endothelial microscope with the same magnification. And so this is more reconstruction based on one volume. When we average volumes, we got a little bit different reconstruction than in the typical endothelial microscope. So we don't see so clearly the hexagonal structure of endothelium, but this is, we can explain that here. It was a very nice paper in Scientific Reports a couple of years ago, based on fluorescence imaging. Authors just made some reconstruction of the RPs, of the endothelial cells, the morphology. And we can see that this hexagonal shape is only on the one side of the cells, of the posterior side. And then there are some quite complex structures coming into the stroma. So what we see in our system is actually projection of those signals with the phase modulation. That's why we have much more complex signatures of our cells than this hexagonal shape. And this is also, okay. So it's also worth to mention that for the corneal imaging, actually the advantage of our method is not only that we can reduce speckles, crosstalk, because there is not so much scattering in the cornea, but also with this technique, we can get much safer configuration for the corneal imaging, because the light beam for full field imaging is not focused on the retina. So we have quite safe broadening of the beam illuminating the retina while we image the cornea, and therefore the full field imaging of the cornea is possible with our system. Okay, so with that I would like to conclude, just so answering the question how far we are to replace the histology. So we see that there is a lot of advancements in high-speed imaging and computational techniques, and we have evidence that scattering provides contrast good enough to differentiate the individual cells, and that spatial phase modulation enables us to reduce these unwanted effects of crosstalk and speckles. And we are hoping that in the next future we will be able to develop really compact and low complex system, and that high speed that will be enabled to work in clinical conditions. Thank you very much for listening. And this is just a presentation of my group. I would like to thank Egidius, David, Piotr, Kamil, and Sławek for their help in this project.
Thank you. That was a great presentation. Any questions? I don't see any questions in the Q&A. I'm going to ask one. So you showed the really beautiful images from Don Miller's lab of retinal ganglion cells in adaptive optics OCT with lots of averaging. And, you know, I think in the past we've thought that you need to average a lot of volumes to get rid of the speckle. Do you think that there are other factors that are driving this ability or inability to see retinal ganglion cells? And just wondering what your thoughts are on that.
Right. So actually, our approach is different. We would like to somehow control by controlling the phase modulation. We would like to get the same decorrelation that Don is getting in minutes within a fraction of a second. So we are just somehow doing the transition of a timing, right, to reduce the spectral signal by using this extra phase modulation. So our approach is simply to get more or less the same effect, but like 1,000 times faster.
Yeah, but have you seen any retinal ganglion cells yet? And I'm curious to wonder if, in addition to this, you know, averaging over time to reduce speckle, there may be some other effect of the tissue changing over time, the retinal ganglion cell scattering, changing with, you know, changing in concentrations of the ions within the retinal ganglion cells may change the refractive index. If there's anything, you know, over these longer time scales that may enable them to be seen in addition to this decorrelation.
I don't think so. So my belief is that this is only the purely, you know, it is very hard to decorrelate the signal coming from the retina. And it really must take time if you want to preserve high resolution, not really doing the spatial compounding, meaning that you can move your image slightly and then average it out. To decorrelate really OCT signals, it requires a lot of phase change, and then in long time processes, like in Don's case, of course you will finally get to this decorrelation. But for the high speed, you have to just help the system by introducing these decorrelations, and I think this is it. There is no any extra physical effect. We have never worked with such a high magnification that it was demonstrated in Miller's paper. But I saw, you know, maybe not such a high contrast signal, but I saw some signal coming from ganglion cells, glia. So in this case, I believe that this is only the process, the physical reason for that is impossible to see with the standard OCT. That the correlation is very, very hard in normal circumstances. So if we can control this decorrelation, it should be the same quality and the same image. We could reconstruct the same image, as I said, 1,000 times faster.
Super. Great. I don't see any other questions, so I think we'll move on to the next presenter. It's my pleasure to introduce Jacque Duncan from the University of California at San Francisco. The title of her talk today is Phenotypes of Remnant Cones.
Thank you. Let me get this going on here. Okay, great. I would like to start by thanking the organizers for including me in this terrific program. I've really learned so much in the last couple of days. All the talks have been tremendous. I want to thank the speakers in this session for introducing many of the imaging modalities that I'm going to discuss today. My task today, or my goal, is to convince those of you in the audience that we can use these novel technologies to identify remnant features of cones in patients with retinal degenerations by showing you some examples. And all this work has been done in collaboration with Austin Roorda, whose talk you will hear in a little while. Okay. So I have a number of financial disclosures, mostly pertaining to data safety monitoring committees on which I serve, as well as support from industry trials for clinical studies that my patients are enrolled in. Okay. So photoreceptors degenerate in patients who have inherited retinal degenerations slowly over time due to genetic changes that cause the photoreceptors not to survive. The photoreceptor degeneration occurs in a stepwise manner, as shown by this histological report from Ann Milam's group many years ago. Initially, photoreceptors lose their outer segments, then the inner segments degenerate, and finally, the photoreceptor nuclei are lost. Patients tend to initially present with vision loss before the photoreceptors are completely gone, presumably due to loss of the outer segments. The photoreceptors may still persist in a way that they are no longer able to function before they are completely degenerated. So remnant photoreceptor structure may be visible and present and indicates cells that have the potential to respond to therapies. I'd like to show you some cases to demonstrate this phenomenon. This is a patient who's 60 years old and has retinitis pigmentosa due to a homozygous mutation in a gene called KIS. Her visual acuity is severely reduced at 2/60 in metric scale or 20/800 in both eyes, so unable to see the big E on the eye chart. You can see her visual fields at the lower part of this slide where she's only able to see peripherally, but the central vision is lost. When we look at her fundus photos, we see typical features of retinitis pigmentosa, but the central area of her macula shows relatively well-preserved retinal pigment epithelial cells. And on OCT, we see loss of the outer segments, but at the center, the outer nuclear layer shows there are certainly still cone nuclei. There's also an external limiting membrane band and maybe some remnants of an inner segment, outer segment band. This is in a patient with severe visual acuity loss and loss of many of the outer retinal layers, but still with persistent outer nuclear layer band, external limiting membrane, and some inner segments of the fovea. This suggests in this patient, the cone cell bodies remain at the fovea, even though she has severe vision loss because she has lost her outer segments. I'm going to argue today that sensitive measures of photoreceptor structure and function can help us better characterize the state of retinal degeneration in patients with photoreceptor disease. Our goal will be to image individual degenerating photoreceptor cells so that we can identify patients that are most likely to benefit from treatments. This might allow us to evaluate disease progression and response to treatments in shorter periods of time than we can with standard clinical measures. But the challenge to this goal is that optical imperfections in even the healthiest of eyes make it difficult to assess individual photoreceptors in living eyes. And as we've heard throughout the course of this meeting, there are many approaches to try and visualize photoreceptors. So one is to use adaptive optics, scanning, light, or laser ophthalmoscopy. This is a picture of Austin Roorda and Yuhua Zhang at UC Berkeley with our first generation confocal AOSLO system. This slide shows that not only can we acquire confocal images shown in this lower left panel, which reject light from any layer that is not conjugate to the plane of tissue, these images allow us to see cone inner segment, outer segment junctions that are waveguiding light when the junction between the outer segment and the RPE cells is intact. Another approach uses split detector AOSLO to collect multiply scattered light and reveal structure from all the retinal layers. In particular, the mitochondria in the inner segment are strong scatterers of light. And so this split detector images provide us with very nice images of cone inner segments. When combined with images from confocal AOSLO images taken at the same location, we can identify cones that have intact inner and outer segments at a given location. We can correlate those images with images from spectral domain OCT. And again, the outer retinal bands here allow us to identify some of the same structures that we're seeing with AOSLO. This dark band represents the outer nuclear layer. This faint band is the external limiting membrane, followed by a dark band from the inner segments, a bright band from the inner segment, outer segment junction or ellipsoid zone, a dark band from the outer segments, and then a bright band from the inner digitation zone, or the junction between the outer segments and the RPE cells. And I've superimposed a little cartoon that helps us see which of these signals corresponds to the signals that we visualize with AOSLO on FOSS images. We can see that the inner segments correspond to these split detector images here, and the inner outer segment junction, the outer segment RPE junction band is seen best with confocal images. So those are all really high resolution ways of looking at photoreceptor structure, but it's very important to ask, how well do those photoreceptors work? Visual function in patients, as I mentioned before, with retinal degenerations tends to be abnormal before we see photoreceptor degeneration. So it is a very early manifestation of photoreceptor degenerative diseases. In addition, imaging photoreceptor structure is important because it predicts mostly because it predicts visual function. Both patients and regulatory agencies need to know how photoreceptor images that we see structurally correspond to visual function. So we need to assess the visual function of the cones we image in patients with retinal degeneration. So here's an example of another retinal disease that affected a young 18-year-old woman who presented complaining of flashing lights in her left eye that began about several weeks before she presented. This was in the context of an upper respiratory infection. She had very severe side vision or peripheral visual field loss, as shown on this visual field test, where this left side of the screen, the visual field is severely reduced. When we look at the retinal image, the color fundus photo looks relatively unremarkable. She has a normal appearing optic nerve and fovea, as does the fundus autofluorescence image from the same location. But there are hints to the etiology of her vision loss in OCT scans, where in her left eye, we begin to see at the location of these yellow arrows, some irregularity and disruption of the inner segment, outer segment, or ellipsoid zone band, although the external limiting membrane band is intact all the way to the optic nerve. If we look at the other eye in the same location, or if we look at these images magnified and then compare them to the other eye in the same location, you can see this a little more clearly in that at the location of these yellow arrows, we start to see disruption and irregularity of this ellipsoid zone band, although the external limiting membrane band is intact almost to the optic nerve. These abnormalities correspond to the location of a retinal blood vessel, which I'll use as a landmark shown with this white arrow. And again, if we compare this to the other eye at the same location, you can see that the ellipsoid zone band or inner segment, outer segment junction band is intact all the way to the optic nerve. So this represents a very asymmetric abnormality in her left eye, corresponding to the area of visual field loss. So again, using this white arrow to indicate the location of a retinal blood vessel, allowing us to superimpose our OCT on our color fundus photo and understand exactly which area we're looking at, we use adaptive optics to look at the cone, inner and outer segments in this area using confocal images. And we see that closer to the fovea, again now magnifying this little box here, we see relatively intact mosaics of cone photoreceptors. But as we transition into this area where there's disruption and irregularity of the ellipsoid zone band, we lose those cone mosaics and do not see intact cones in that location. If I magnify here, you can see even closer, there might be evidence of what look almost like RPE cells. And compared to the same location in the right eye where we have normal cone mosaics, there's a big difference where only in the far temporal area of this image do we see any residual cones. Well, this patient had a condition called acute idiopathic blind spot enlargement syndrome, which is an inflammatory condition that causes abnormalities to the photoreceptors corresponding to severe visual loss. And as we've seen, abnormalities on OCT and AOSLO images. But it is an inflammatory condition that recovers with time. And in this patient's case, over time, at 3 months and 1 year later, the visual field loss she presented with improved to the point that she had almost normal vision by the end of a year. We imaged the patient again a year after initial presentation, and you can see in the movie with these two images superimposed, areas where it looked like there were no cones or may have been even RPE cells began to show cone profiles which corresponded to the recovery of her visual field. So this demonstrates that we can see remnants of photoreceptors that have the potential, in inflammatory conditions at least, to recover visual function. And coincident with that, we can see the restoration of their cone profiles and cone waveguiding when imaged with AOSLO. That's a pretty crude defect that affected almost half of her visual field. And we would really prefer to assess cone function on scales similar to what we see with our AOSLO images, to enable us to study the function of individual cones. So it turns out you can actually use adaptive optics not only to visualize cones with high resolution, but also to deliver little flashes of light very precisely to small regions of cones. And this is a technique that was first reported and described by Will Tootin at UC Berkeley. This is a picture of what the subject sees, and in real time with high-speed fundus tracking, stabilize the flashing light on small groups of cones to really probe the visual function of the cones that we are seeing with high resolution using adaptive optics. So Kat Foote, who is now a PhD from UC Berkeley, was formerly a graduate student, chose to use this approach to compare patients that have retinitis pigmentosa caused by very different mechanisms. She compared patients who have rhodopsin mutations, which is the most common cause of autosomal dominant retinitis pigmentosa, that causes early night blindness and subsequent visual field loss and vision loss over many decades, but is caused by a mutation expressed exclusively in rods, to patients who have mutations in the RPGR gene. This is the most common mutation in patients with X-linked retinitis pigmentosa. This also causes early night blindness, but tends to cause earlier and more rapidly progressive visual field loss and blindness. Unlike rhodopsin, RPGR is expressed not only in rods, but also in cones. So just to explain in a little greater detail, rhodopsin encodes a protein called, Rho is a gene that encodes a protein called rhodopsin. The Rho gene is localized in its expression to the photoreceptor outer segments of rods and plays an important role in phototransduction, or taking light and turning it into a message the brain can understand. Whereas RPGR encodes a different gene that is localized not to the outer segments, but to the connecting cilium that between the inner and outer segments, that is expressed both in rods and in cones. And it is plays an important role in trafficking of proteins from the inner segments where they are synthesized to the outer segments so that they can facilitate vision. So we enrolled a total of 4 normal subjects, 4 patients with rhodopsin-mediated autosomal dominant RP, and 5 patients with RPGR-related X-linked RP. And all the patients were imaged with adaptive optics, scanning laser ophthalmoscopy, and microperimetry. Here are some examples of the patients that we studied. In each of these patients, we're looking at a left eye, and the fovea is shown towards the left-hand side of your screen with greater eccentricities moving to the right. We used adaptive optics microperimetry to deliver a little flash of light at 2-degree intervals. And here I've shown the confocal and split detector images of the photoreceptor structures at each of the locations where the patient's vision was tested. In normal eyes, we see the thresholds were very low, or the sensitivities were very great throughout all the locations we studied. In the patients with mutations in rhodopsin or RPGR causing RP, we see loss of sensitivity beginning at about 6 degrees in both of them, and very good function right at the fovea. But interestingly, at about 4 degrees, we see a difference where there was better preserved function in the patients with rhodopsin compared to the patient with RPGR mutation, with X-linked RP due to an RPGR mutation. We'll highlight these areas in the next slide and show you that by counting the cones, the cone density was essentially very similar, or almost the same in both eyes, but the sensitivity was much lower in the patient with the RPGR mutation. The threshold was higher, indicating that these cones did not function as well as the cones in the patient with the rhodopsin mutation. Well, if we divide the microperimetry sensitivity by cone density to get an idea of how sensitive each cone was in the patients that we studied, we see that in comparison to the normal eyes, the rhodopsin sensitivity was essentially the same, but the patients with RPGR mutations had significantly lower sensitivity or higher thresholds, indicating worse function at the same cone density. If we look at the outer segment lengths, we also see that the outer segments from the RPGR patients are shorter than the patients with rhodopsin mutations. But if we look at the microperimetry per outer segment thickness, there is no difference. And this indicates that the rhodopsin outer segment length, the RPGR outer segment length was significantly lower, but had the same sensitivity, indicating that the RPGR patients had worse sensitivity per cone density and per outer segment length compared to the rhodopsin patients. This is perhaps because the RPGR mutation is expressed not only in rods, but also in the cones we're studying, while the rhodopsin mutations are expressed only in rods, and we're really probing cone function here. But it does show that RPGR-related RP shows a dissociation between the function and structure, and patients with RPGR-related RP might show some improvement in function in response to treatment. And this is important because there are at least 3 ongoing clinical trials enrolling patients for gene therapy who have mutations in the RPGR gene right now. I'd like to finish with one last example of remnant cone structure in patients with retinal degenerations. This is a patient another young woman who presented following an upper respiratory infection with acute loss of acuity in both of her eyes. Initially, her vision was reduced to 20/80 and 20/140. She came back for follow-up 5 years later, and to my surprise, the visual acuity in this eye had improved to almost normal, 20/25. If we look at this a little more closely, you can see the structure does not look normal. There's a very well-demarcated area of abnormality of the retinal pigment epithelial coloration. And if you look on OCT, we saw a little area of defect or a little discontinuity in the ellipsoid zone band, which I'll show you at greater magnification right here. So again, the ISOS junction or ellipsoid zone band is discontinuous and hyporeflective at the center. And the external limiting membrane band, although it is intact or continuous, shows a very ragged edge to at the posterior element of it. We studied this patient with adaptive optic scanning laser ophthalmoscopy and saw well-preserved cone mosaics essentially everywhere in the mosaic, except for this area that had this very well-demarcated area where we didn't see any cone profiles at all. Although this patient's vision was 20/25, we were able to, not absolutely perfect, but quite good, we were able to track the location at which she looked at a small spot when we modulated the laser. We found that, to my surprise, the place she liked to place the location that she's looking at was right in the center of this area that appeared to have no visible cones. So it was surprising that this patient would still fixate on an area that appeared to have no waveguiding cones. And we decided to study this with tracking scanning laser ophthalmoscopy. Initially, we delivered flashes of light to this area where the cone mosaic looked relatively intact and found that she had excellent thresholds within normal limits. But to our surprise, that right in the center of this lesion, there were measurable thresholds, although they were elevated by about a log unit. We then decided to deliver, you could wonder if maybe there was some scatter or she was able to perceive the light using peripheral flashes. So we decided to deliver or probe this visual function using an acuity test by modulating the AOSLO laser to deliver a tumbling E. And as you can see in this video, the patient chose to put the letter E essentially right in the middle of the area with no waveguiding cones. When she was presented with this tumbling E, she identified the orientation of the E correctly 48% of the time. And the chance, and this is when we limited our assessment to the times when the stimulus fell completely within this area of where there were no visible profiles. So the chance that she would get 48% of get the correct answer 48% of the time due to chance alone upon 31 trials is only 0.13%. So this was significantly better than we would have predicted based on chance alone. So we've decided to call this phenomenon dysflective cones. This phenotype is characterized by intact, hyperreflective external limiting membrane bands in the presence of a disrupted ellipsoid zone or ISOS junction band, but in patients who retain visual function, not perfect, but still measurable visual function. These represent regions without visible cones on confocal images, but may have cones with inner segments that lack intact outer segments. And this is not a specific phenomenon. It has also been reported by Joe Carroll's group in response to blunt trauma, where again, he used split detector to show that there were some residual inner segments shown on split detector images, even in areas where there were no waveguiding cone profiles on confocal images. Functional testing may give us information that cones persist that have shortened or abnormal outer segments, and these dysflective cones are likely to be capable of vision and possibly most likely to recover or respond to treatments for patients with retinal diseases. So to summarize, remnant cone structure in patients with retinitis pigmentosa results because photoreceptor degeneration initially affects the outer segments with vision loss, and then subsequently causes death of the inner segments, and then finally this photoreceptor nuclei. Because visual function is lost before structure, we have chances to use high resolution retinal imaging with OCT and AOSLO to identify residual photoreceptor structure that can demonstrate cells which have the potential to respond to therapies. And with that, I'd like to thank all my collaborators, especially Austin, Roorda, and Joe Carroll. In addition, none of this work would be possible without Swati Bhargava and Jessica Wong. And they are seen here moving our AOSLO system into the new Wayne and Gladys Valley Center for Visual Neuroscience. So we are all kind of in the process of a move. And these are the funding sources that made all this possible. At this point, I'm happy to answer any questions. There are some questions in the Q&A.
Yeah, thanks, Jackie, for this really beautiful talk, which is a great demonstration of why we're all doing important work, doing high resolution structural and functional imaging. There are some questions in the Q&A. There was also a hand up I saw in the participants. So I'm just going to allow the first person who asked a question there to speak, if they're able to.
Should I just?
You can go ahead and answer that question if you like.
Oh, okay. Well, let's see. Thank you, Austin. That wasn't the question, though. The question was, we have two questions. It looks like Ethan, actually, who probably could speak if he wanted to. Ethan said, in some retinal disease, oh, wait, Ethan would like to answer the question live. I don't know. Are you wanting to answer this question or you want me to, Ethan?
I just marked that you were going to answer live.
Oh, I'm going to answer it live. Perfect. Okay.
Yeah,
in
please.
some retinal diseases, there's photopsia. Is it from an inner segment lesion? It's an excellent question. I will tell you what I think, but I'll tell you that this is just my opinion. Okay. There are a lot of patients with inherited retinal degenerations that experience photopsias, as you mentioned, in some other retinal diseases too. My interpretation of this is that may reflect activity of the inner retina, whether that be bipolar cells or imprint cells or horizontal cells that are undergoing rewiring, or in the absence of normal communication from the photoreceptors as they undergo degeneration or death. The only way the retina knows how to respond to any kind of abnormal stimulus is by perceiving a flash of light. So my understanding is that in eyes with disease of the photoreceptors, the inner segments may be responsible for this, but certainly there's communication going on with the bipolar cells and then the ganglion cells to allow the subject to perceive light. So it's unclear whether it's coming from the inner segments or whether it's just it may also occur in patients with the loss of inner and outer segments whose bipolar cells are firing in response to damaged photoreceptors. And again, someone, maybe the same person, said I showed a case with enlargement of the blind spot and spoke of photopsias. That's true. Both of those conditions, acute idiopathic blind spot enlargement syndrome and acute foveolitis, both are often associated with flashing lights or photopsias. And again, we believe that represents interretinal responses to disturbance or abnormality or sometimes degeneration of the photoreceptors. I hope that answered the question.
That's great. There was a second question that came in the chat, actually. It says, how do you interpret that the sensitivity of cones is weaker in one mutation compared to the other in the RP study?
That's a great question. And here's what we think. You know, we think that how we interpret that is two things. We think, first of all, the patients with mutations in the RPGR gene have a mutation in a gene that is not only expressed in rods, which cause secondary cone loss and cone degeneration in response to rod death, but the RPGR gene is expressed by the cones themselves. And so we expect or suspect or think that the RPGR sensitivity is worse than the rhodopsin sensitivity because the mutation in RPGR is directly expressed by and affecting the function of those cones. But importantly, I think that paper, which was published this year by Kat Foote and the rest of us, is an important demonstration for, I think, the first time that there is a dissociation between the function and the structure in patients with RPGR mutations. And I don't know that that's been published before. It's important to say that many retinal degenerations cause abnormal function out of proportion to cone loss, and that indicates those are potentially amenable to improvement in visual function in response to therapy. So if RPGR patients who are treated or receive gene therapy can not only demonstrate preservation of their cones, but can actually show improvement in their function, that would be a tremendous advantage for patients who receive treatment. Okay, Kate, I think you're on mute.
Were there any more questions for Jackie? Yeah, sorry.
Thanks, everyone.
Okay, if there's no more questions, I think we'll move on to the next talk. So there has been a cancellation. José will unfortunately not be able to join us today, but that allows us to catch up for time. So I'm going to move on to the next talk, which is from Wolf Harmening on cone-targeted visual psychophysics.
Yeah, super. Let me share my screen here. That's the wrong one. Let me share the other screen. Okay. Can you hear me and see the slides?
Yes.
Super. Okay. So just a short view onto our little, let's say, outsider world of psychophysicists working with high resolution systems. So we're a small group in the University of Bonn, and I'd like to acknowledge all the people working in my group here. And I would like to give you like a short view into our systems and what we do. So probably there's not enough time to talk about everything. So we have a website, and I invite you to go there, and there's some PDFs you can download, some book chapters, type of review style. So I hope that will help. So like we've seen now for a couple of times, we can look at the retina in really high resolution, and we can see single cones and photoreceptors, and that's terrific. And what really I found most astounding at this, I think that's my view on this, is that you're looking at live tissue who's directly staring back at you as the operator sitting in these systems. And the idea then is, of course, to somehow tickle some of these cells or maybe groups of cells, and to see how do they respond, and how does this affect perception of the person who's sitting there. So the idea, of course, is to do cone-targeted psychophysics. So ideally, you want to direct light at the retina, just at tiny places on the retina, perhaps ideally just to a single cell or maybe groups of cells. And since the person is just sitting there and can tell you what he or she sees, you can do psychophysics. And in this talk, I would like to just briefly go over how we do this. We need some specific techniques, and they are maybe very specific to this type of psychophysics, and also what we can learn with this. So first up, we need a system, and we have an AO-SLO system, and now you've seen this a couple of times here in these talks, and ours is quite the same as those types, so it looks more like a physics laboratory. And these types of systems are kind of rare, distributed around the world, and you can also see where it all stems from. This, of course, the lab of Austin Roorda But there are a couple of ones out there right now, and ours is the one at Bonn, which we use and which are kind of more or less similar setup. So we can also like collaborate well and share our results among the groups of us. So basically what happens is that you into the beam that scans across the retina, I hope you can see my mouse pointer, while the beam scans across the retina, you turn the light on and off quickly to modulate the beam and in that way produce a visual stimulus. Now Jackie just have showed this in her talk as well, as you could see with the E and the little blinking spots. So that's exactly the same way as we do it. We use a fast light switch to do this, which is an acousto-optic modulation. We're of course not the first ones to do it like that. So people have shown this almost 40 years ago in more analog style, but this is a really great schematic that shows you while the beam is scanning across the retina, you have information about the pointing of this beam due to the signals that go into these scanners. And if you have something that can turn the light on and off quickly and in synchronization with that, then you are able to produce a stimulus. This is retinal contingent. This is way back footage, but they can do exactly the same thing as we can do now back then, and did so. But the difference is now is that we can do this while at the same time seeing each individual cone photoreceptor and maybe learn something about their arrangement relative to a stimulus. So to give you an idea how this looks from the perspective of the subject now, you're sitting in our system and doing a psychophysical task, you would see something like that. Although this would be colored, this is 840 nanometers to our camera that has been recording this. This looks black and white, of course, but you can see the scan lines. You can do some flyback of the horizontal, the vertical scanner. There's also some aliasing going through this. This has to do with the camera recording this image. Just an idea of the scale here. So you all know that rule of thumb, of course. So if you stretch out your arm at arm's length, your thumb is about 2 degrees wide. So that gives you a nice reference point. So if you do that with your finger, your fingernail is about 1 degree across, right? So, and all of what we do here is inside that fingernail. It's a little smaller actually than that. So our display is not like you would used to be in psychophysics, normal psychophysical tasks where you sit in front of a screen and doing some tasks. Everything is very tiny and just for the perspective. And now inside that small visual field, we can produce stimuli. And in this case, we've simulated how it would look like if you would present something that is on the order of a single cone. Now, this is of course magnified, but you see here there's a little green area, which is one that, well, roughly goes into a single cell or maybe a group of cells. This is false colored now, so that it makes more sense. This is how you would perceive it when you're sitting in front of the system. Well, a few technical details to point out to the experts here. So in order to produce this with high visual contrast, we need to eliminate some of the background lights that are produced by these acousto-optic modulators, these fast light switches. We've solved this by cascading 2 of them, put them in a kind of daisy chain, so the output of one goes into another. So by that, we kind of multiply the contrast that we have in this image. So we have high dynamic range in all of these stimulation protocols. Also, there's also technicality, and also for the experts again, if you're using more than one wavelength, you have to be concerned about chromatic offsets that are introduced, one by the eye itself called transverse chromatic aberration, but also by the system itself. So in all together, we call it TCO, transverse chromatic offsets. And we have now a way to measure that to a fine degree. And we can see Nicholas here in the system, where when you use that kind of system, which is measuring the pupil position relative to the beam that goes into the eye. If you don't do that, then you will end up with, could end up when the subject is moving just a little bit like they normally would do, with a larger area that's been stimulated than you actually want to. This is about 2 degrees cone images here. But if you want to go really into the fovea, maybe even to the center, you need something which is more finely tuned. So this system allows you to do that. Okay, so we're almost done. We have everything in place. We can make the photoreceptors visible. And for that, we use an AOSLO system. Now we've heard a couple of times that it's possible. We want to target the light to specific cells, maybe groups of cells, maybe a single cell. And with that, we use this high dynamic range acousto-optic modulation. And the last part is we also have to be concerned about eye motion. As you've seen maybe in some of these videos before, there's big motion artifacts, which comes from, even if you fixate very well, you have still fixation on eye motion that will translate the cones that you want to target actually over a larger area. So here we use a software that's been developed at Berkeley also to do that in more or less real time. Just one word about that. So if you look at different subjects sitting in our system, they could be very different motion patterns. And here's one, for example, to the left that makes a lot of fixational eye motion, and the one on the right seems to be more calm and seems to do less. In both cases, you would miss probably most of the time the cone that you want to hit if you don't correct for any of this. So this is how this stabilization works. You break the frame that's been acquired into strips and compare that to a reference frame. And if you do that strip by strip, you build up a new motion corrected frame. And this can happen really quick. And that's why the software from Berkeley comes really into play. And as you, when I blend out the edges here, you can see that the cone in question, for example, this one here, stays at the position. If you combine that possibility with the possibility to code a stimulus into the beam, you end up with something like that, where you can produce, for example, this letter E here, the tumbling E, into the very center of the fovea. So this is a person looking at it and doing normal fixational eye motion. And on the right, I just cropped the frame from the left around the letter E, or actually placed on fixed in the fixed region on the retina. So you will see some residual motion in the letter E, but overall it's quite stable. So Kavitha Ratnam did some nice work on this, where she showed that this tiny motion that's still normally every time it's is present in normal viewing actually helps resolution, as you would maybe I don't know if one predict that, but so in normal viewing, the E would slide over a couple of cones at all times. But if we lock it, like I've showed before, into one position, then the number of correct responses goes down actually. So you're worse at seeing this. And here's just maybe a naive simulation of how that could work. If I play this, you see the normal sliding retina underneath the E, and if we just simulate how much information is present at every cone, you will see that you can detect maybe this the orientation of the E much easier than if it's locked into place and it just has this specific sampling property of the cones just as they happen to be right there. So let's now move into more recent results. And specifically what we want to do here is to move into very center of the fovea. So as you can see from this image, we can resolve those cones, but also you can see that the diameter and the distance and the density rapidly changes if you move to that area. So everything gets a little bit more complex or maybe a little bit more complicated because it's much denser and the structures are much finer. So on Monday, you heard from Nicholas. He's producing small spots of light and doing basically microperimetry at those locations. And especially you could look at, well, how many cones right in the center of the fovea have been stimulated, and compare that to the sensitivity that's been recorded at that place. Similar as Jackie just has shown, but with smaller spots. For this last part, I want to focus not on sensitivity, but also again on acuity. So our ability to separate points in visual space. So what we see, and that's normal, is that subjects have very different cone densities in their foveal center. And these differences can be quite significant. In this case, you can see here on the left, someone with about, well, 12,000 cones per square degree. and the one on the right about 17,000. We even have some cases where go up to 19,000 cones per square degree. So the factor is quite large between just a normal population. They all have normal vision. But the question here is, does this particular subject here has better resolution in everyday tasks? Or in this case, we ask this with a visual acuity task. So how to do that? So first you have to see all the cones, and then comes a tedious task, and Jenny has perfected this now to annotate these images. She uses a CNN that has been trained to detect cones in these type of images. They have to be specifically tailored to work on foveal images because the structure rapidly changes over space. And you always have to go manually after that, so that's normal. Then she calculates the density from these cones by segregating this into Voronoi cells, and by always taking a set number of cones, you can actually make these very fine maps of cone density. Now, if we organize this data, now this is data from 12 subjects here, and it's organized by the right eye to the left and the left eye to the right here, as if the person is looking at you. So there's 12 people, 24 eyes. If you look at this, and just for the topography, so just looking at how the distribution of the cones is laid out, you see maybe at first glance, well, there is a bit of a horizontal vertical isotropy. So you have a steeper decline of cones in the vertical direction than the horizontal. And basically, we see some mirror symmetry between the eyes, which would be interesting. The other thing is, if you just now look not at the absolute numbers, actually, we can order them from low to high. So we see this great range of, like this person has a high foveal density, and this one the lowest in our group. That they span quite a bit of that range. And now we are able to test those people in the visual acuity and try to correlate and see if these things go together. So the way we do it, and Jackie just showed it in her system as well, it's the same way. We produce a visual stimulus, and maybe I can just play this video. So this is just looped. So the subjects see that tumbling E for about 500 milliseconds, and then they have to respond in the psychophysical task, and this repeated several times, so to land at a threshold, and then you repeat that thresholding a couple of times to get an average threshold for that person at that location. So what we also do, and this is just a minor point, before we do all that, we record the subjective area of where the people fixate with what's the exact area on the retina, on the cones that the people use to look. And that's called the PRL, the preferred retinal locus of fixation. And we use that with a blinking dot like that. So now here's just a part of the results, because they don't fit all on the slide, but we've selected just 6 of them, arranged again from highest density on the left to lowest on the right. And you see that, first of all, the area of the PRL, which is this ellipse, does not usually coincide with the area of highest cone density, which is this star here. And also there's again, the difference between the cone densities nicely shown here. Now you can calculate based on the highest peak cone density just by assuming Nyquist sampling theorem, that what's the smallest distance between visual objects that this retina can just resolve. And the smallest spacing between the cells is about 0.5 arc minutes in this case, and about 0.6 arc minutes in this case. So it's not big of a difference. If you calculate into arc seconds, then you land up with something like 26 arc seconds in this guy and 30 in this eye here. So now let's see it, look at the results if that matches. And this is what we find. So peak cone density is on the x-axis, and the tumbling E acuity on the y-axis. You can see there's a nice, more or less linear relationship, and it's true. The people with a higher peak cone density also have higher acuity, and it goes quite into the range that you would predict just by assuming the Nyquist theorem, which is this green line over here. Now, when we look exactly where the subject have fixated with. It's not the location where it's highest peak cone density. So it's not the star, but actually it's a little bit outside of that area. So if we correct this data to more fall on the location where with the cone density that the subject have used, then this data looks like that. So these two slide together, and depending on how you define a psychophysical threshold, we use a quest method, but you could do it differently. Then this will shift around in the vertical direction as well. So we believe this really nicely shows that the visual system here uses all the information that's available at the level of each of those cones. When you separate these two between the dominant eye and the non-dominant eye, that's also interesting to see that this, well, basically it shows the same correlation, but also they are taken apart from each other. So the dominant eyes usually have better acuity, which maybe makes them dominant, but I'm not sure if that's clear. But also the stimulus, the cone density in the dominant eye usually was higher, not in all eyes, but in most of them. Okay, so to sum this up, in this case, visual acuity is directly related to the sampling capacity of the retina, which is interesting because at normal vision, if that subject just is at their habitual optics looking around, then probably the blur on the retina is way higher than it is the case when we use our adaptive optics system, where we remove all the blur and have really high contrast letters presented to the eye. But it still seems to be the case that all this information is preserved and up to the perceptual level where they can actually distinguish the orientation of the E. In our cases, myopic eyes also, because, and that's also what the group from Berkeley have shown, that they have higher cone densities at an angular scale, is that they should have better visual acuity, and that also is the case in our eyes. Although we have to say we didn't test like really high myopic eyes, just mildly, but it follows the same trend. And just another point, I didn't go into too much detail about this, is that the offset between the star here, the PRL, the highest cone density, and the PRL, which is this ellipse, follows a systematic offset. And we will show this in an upcoming publication, but we think we could learn something of how the visual system maybe drives that location into where it actually is in our subjects. Okay, so I would like to thank all of our collaborators and our funding sources, and very much for your attention. I'm happy to take questions.
Thanks, Wolf. Beautiful talk. Do we have any questions from the audience? I don't see anything coming through the Q&A. I have one. Really great to see how far this work has come now over the past 10 years or so since Austin and I published a paper that sort of predicted the results that you had there. I'm curious, have you looked at, with your targeted stimulus delivery, to try to deliver the E to the area of peak cone density and compare that to the PRL?
No, we haven't done that yet, but it certainly is on the plate. But I know that Kavitha Ratnam did some of this. It's in her PhD dissertation. I would have to scratch my head out a little bit to what she found, but maybe Austin can say something to it. But there she looked at like carefully displaced positions of where to sample from, and if I remember correctly, it also didn't follow like a straight prediction, but I'm not sure. Maybe Austin reminds us.
It was pretty flat. So the fovea was no better. The acuity, as the way we measured it, it's a little challenging, but it was quite flat across the area that included the PRL and the fovea. I had a question, because you predict that myopes should have better acuity, but there are many studies, including ones that that we've done with Ethan, that suggest that myopes don't have better acuity. So well, it'll be interesting to see. what your studies show if you include more subjects, but what were the refractive errors of the subjects that you did study?
So as I said, not really high myops. I think the one with the largest refractive error was maybe 2.5 or something like that. So
but even
it's not a great range we're able to sample from.
Even in Ethan's study that he did in Berkeley years ago, it was low myopes that even showed a significant significantly lower visual acuity despite an AO correction. We did not measure the cone density at the fovea in those subjects, though, at that time. We were unable to.
Okay, there's a hand up, the attendees here. I'm gonna enable you to talk. So please go ahead and ask your question.
Hi, Wolf. This is Tos Berenscott. Great talk, thanks. I'm just curious about this PRL and this higher focal density. Can you hint for an explanation?
Oh, first off, I have to say that the amount of offset that you see between the PRL and maybe the P cone density is tiny. It's very, very small. So it's just a few arc minutes. Most of what we see is below 5 arc minutes displacement. So that kind of limits of like your, let's say, evolutionary hypothesis that you might have. Maybe it has to do with angle kappa, or maybe it has to do with binocular vision, and that, well, these optical trajectories try to point at some location which is a little off to where they actually land on the retina relative to the cones. But so I could just say right now that we observe a systematic offset, which is away from a nasal inferior quadrant, and all of these offsets are on the other side. So, and it's symmetric between the eyes, and I'm not sure if Jenny has shared this type of data yet. Maybe it was at Arvo, I think. But this is our latest finding. So yeah, so we're currently struggling with to find a good explanation for that. But that's our observation.
Okay, thanks, Wolf. And we'll move on to the next talk now. The next speaker is Dierck Hillmann from the University of Lubeck, speaking today about functional retinal imaging by holographic OCT.
Okay, great. Thank you. Do you hear me?
Yes.
Very good. So then let's start. So I'm going to talk a little bit about functional retinal imaging, the work that we've been done over the last couple of years here in Lubeck as a collaboration between the university and Thor Labs and the Medical Laser Center Lubeck, actually. And so I want to start a little bit about holographic OCT of the retina, and then I'll go on to the functional imaging directly after that. Wait, you don't see my screen, do you?
No.
You see it now?
Yep.
Yes.
Looks good.
So first of all, why do we need holography for that? So in principle, if we have a camera, for example, a camera acquiring the retina, we have access to the intensity of the light, but we don't have access to the face. So if we had a face camera that would be, in principle, able to acquire the face, it would give us tremendous possibilities in what we could do with the data. And we've seen this in talks previously, for example, by Michael Adlan or by Maciej Wojtkowski on what these things can do. And now to acquire the face, actually, this was solved some time ago by Dennis Garber in 1971, where he was awarded the Nobel Prize. We use the light directly backscattered that would give the intensity image, and we superimpose this with reference light, and the interference pattern actually gives us the information on the amplitude and the phase. And what we can do then is we can propagate these wave fields, which essentially means we can refocus the images. We can also insert virtual lenses and other optical elements. And of course, this also means we can reshape the wavefront. So we can do some sort of adaptive optics with that. And we can also use the phase to really observe tiny changes in the optical path lengths of the light that we acquired. For example, do some sort of profilometry. And we'll do this for the photoreceptors and for other layers in the retina to really get some functional signals later on. And OCT, in essence, it actually is sort of a holographic technique. We have light that is usually split up in some reference and some sample arm, and the interference signal is detected, for example, by a spectrometer. And so in principle, we could get the holographic information out of an OCT image. But the problem is that usually the sample, so in this case, the human eye, it's moving very rapidly, and we don't really get the correct phase information, because for every A line that we acquire, this phase is sort of disturbed. It is changed by the eye motion. So our approach to circumvent that is essentially using full field data, but a lot of people have actually used this holographic OCT approach, and I just want to show the most important works in that regard. The first, I think, using a holographic reconstruction method in OCT is back in 2007, and after that, all these interferometric synthetic aperture, where Stephen Beaupert's group essentially showed that all the layers of an acquired sample can be refocused in a single step. And then even later, it was shown by various groups that also adaptive optics can be performed digitally. So our approach to achieve this holographic imaging is that we use a full field approach. We have an area camera that is very high speed. We have a swept laser that changes the wavelengths, and we split the light in a reference arm and in a sample arm, where we illuminate, in this case, retina with a collimated beam, and the backscattered light is imaged back onto the camera. And this acquires all those lateral points that we usually would acquire with scanning simultaneously, and we do this for multiple wavelengths. And then we have, in essence, our OCT volume that we can reconstruct. And this requires some various components that are not really standard OCT components. As for swept source, that is sweeping way slower than usually. So we have only 50 nanometers bandwidth and a center wavelength of 840 nanometers. But we can bring, because we have not a focus beam, we can bring about 5 milliwatt onto the retina. And then we use the high-speed camera, which is really the heart of this setup. This needs to acquire data with about 60,000 frames per second to get really sharp and non-blurred images. And this means the area of interest that we have needs to be restricted to about 800 by 400 pixels. And we usually acquire 512 images per A-scan. And this gives us actually an A-scan rate of about 40 megahertz A-scan rate. And the imaging in A usually, we usually use 0.1 NA, but we can also go up to 0.2 NA with this setup. And this is what it looks like. It's essentially a very simple setup. We don't have many components, but we have this stabilizing mask where essentially the test subject is put into, so that we don't have much movement, because even at these acquisition rates, even with these this high-speed camera, we still have the problem that too severe motion can cause problem. And also the mask helps us to really put the retina in the same position for the consecutive measurements. So if we acquire this data and we construct standard OCT reconstruction, we see these images and we see that these kind of look relatively blurred. So what do we need to do? First of all, we need to get rid of all those artifacts in there, which we can do by basically subtracting a reference, getting more cleaner images. And to get further in the reconstruction, we need to understand where these trouble comes from. And essentially what it is phase errors that we have in our images. And there are actually two kinds of phase errors which are very much related. And the one is, in this full field setup, we have reduced axial resolution, which comes due to axial motion. The phase changes by motion of the retina during the sweep of the laser. And this is a phase error that we have in the axial direction. And at the same time, we have some sort of phase error in the lateral direction, in the Fourier transform of the lateral direction. And this is essentially what aberrations cause. So we don't have a sharp image, but for every beam direction, we get a different phase due to the eye aberrations. And if we if we know how to correct one of these phase errors, we can actually also correct the other one. We can use the same algorithms to do that. And that's what we do. So we get sharp images axially, and we can also correct the aberrations. And we can co-register these volumes so that they don't move, and we can average them and segment the interesting layers. And having all this processing done, which is all done in the computer. So the setup is very simple, but the algorithms get rather complicated. We get, well, relatively nice images where we can see the single cone photoreceptors, where we can see the nerve fiber layers, and all these layers can be sharp essentially at the same time. So, and what we want to do with these images now is functional imaging, because we have a very unique capabilities. We have a relatively large field of view. We have 3D volumes, and we get up to 200 volumes per second. And these volumes, they are in principle phase correct. So the phases for all these volumes are acquired logged relative to one another if we apply some additional corrections. And this brings me to the second part where I want to talk a little bit about the functional imaging of the retina by holographic OCT. And we know, as we've seen in the initial talks, that the retina has this layered structure which comprises different neurons. And now if we want to, or if we put light on these neurons, the photoreceptors absorb the light, and we have the signaling cascade that walks basically in up to the inner retina. And there are all these chemical processes taking place. And if we could detect the function of these cells, of the neurons or the photoreceptors, this would be a really important tool that we could use in basic research, in diagnostics, or also in therapy monitoring. And for this reason, there has been lots of work by different groups on functional imaging of the human retina. And I guess this is probably not all of them, but you can see that there's been a lot of interest over the years, I guess starting probably in 2005, maybe even earlier than that. And even the latest publications are very recent in this year. And so what could we use to do this functional imaging? What kind of contrast mechanism could we use if we have this probabilities? And what we want to use is we want to do this labeled free. So we want to use the fact that neurons might actually change their scattering properties after they've been activated, after there has been some sort of stimulus that really was absorbed by the photoreceptors and the signal moving down these neurons. And this could be due to several reasons. They could, for example, change their size, which might be due to ion currents taking place, or due to osmosis, then causing some water flux following those concentration changes due to their activation. And actually, with OCT, we can, with very good precision, detect size changes in the different retinal layers. For example, we can use the phase, as I mentioned earlier, as can be done in holography, to really observe whether the thickness of neurons or photoreceptors or whatever has changed. And so what we did is we took our setup, we added a projector that has a mask that is illuminated from the back, and the mask is then projected onto the eye so that we can use specific patterns that we project onto the retina. And we have fairly low power in this pattern, which is about 10 microwatt. Usually we use either a checkerboard pattern or an X-shaped pattern. And what it looks like, if we have a look at those OCT images, the en face layer of the cone photoreceptors, we see that essentially in the backscattering intensity, we don't see anything. But we want to use the phase. So the phase actually would correspond to the travel time of the photoreceptors on neurons if we would compare the phase of the two layers of the, for example, the outer segments. And how do we do that? Well, we need to add to our previous processing some sort of phase evaluation. And this works as follows. So we take our OCT image, then we have a look at, for example, one layer at 2 different times. And if we look at the face at just one specific time, it looks like absolute garbage. There's nothing in there that looks like any meaningful structure. But if we take the time difference between 2 volumes, for example, volume 5 and volume 37, for this data set, which are apart about 7.2 seconds, we start to see some pattern in there. So that is the phase changes that took place in these 7.2 seconds in this respective layer of the retina, which is in this case the inner segment, outer segment layer. So we can take not only the inner segment, outer segment layer, but we can take the very same phase difference of 2 time points for the outer segment tips. And now we can even increase this signal by taking, well, even the layer above the inner segment, outer segment, and the layer below it, and average those. We average the complex values and then use the phases. And we can then build the phase difference, and suddenly we start seeing the pattern that we use to stimulate these photoreceptors with. And we can then apply a Gaussian filter to make even nicer images where we really can see this pattern. In this case, it's been an X-shaped pattern, obviously, pretty clearly. So we can then even extract some sort of phase signal of the stimulated area, and we can get some time course of these layers, and that over multiple seconds. In this case, that's been over 15 seconds, but we already see that starting after 5 seconds, around about, the signal becomes bad. We have phase wrapping, and this signal starts to deteriorate. Nonetheless, for shorter times, we can do pretty nice measurements with that. For example, this has been one of our initial measurements. We have a very brief stimulus of 50 milliseconds. And then we have this checkerboard pattern, and we evaluated the phase over there. We see some initial shortening of the photoreceptors and then some increase afterwards. And these measurements are highly reproducible, so we can do multiple of these measurements. We see a very similar time course every time. And this might also explain previously observed intensity changes of, I guess it was flood illumination, AO imaging, where essentially the outer segment and the outer segment tips kind of can interfere, and this interference may then cause changes in the backscattering intensity. And well, we can see that it is at least not thermic. It is. It appears to be some sort of physiologic process. This might be due to this osmosis, as mentioned. And well, essentially, it's not thermic because the expansion would stop directly after the 50 milliseconds where the stimulus took place, and also we wouldn't see an initial shortening of the photoreceptors. We can use, or we can do some further analysis of these signals. For example, we can have a look at when the signal comes back down to the base level, and with this 50 millisecond stimulus, we get it down after about 3 seconds. We can also have a look at different intensities. So this has been a very bright stimulation, and in that case, we see that the this initial shortening of the photoreceptors decreases, but the slope afterwards, the rise of the length of photoreceptors, remains the same for these intensities at least. And I can also maybe mention that by now we have gone even further down with these stimulation intensities, and we do see some change in the initial slope. So it is, or we have been in some saturation process here. And we can also increase essentially the signal of these photoreceptors if we stimulate with a continuous, with continuous light. So we then see that the phase even begins to wrap, and the signal becomes, well, the color wraps, but we can unwrap these phases and see some time course over 3 seconds, which is very strong. And if we have a signal that is this strong with some additional post-processing, we can even assign this signal to single cones. And we can see here, what we observed was that we see some cones not responding very well. And if we have a look, for example, here, we see that the same cones over 2 measurements that were apart about 10 minutes, they did not react to this stimulation. Okay, but what if we want to go further? What if we want to do longer measurement times? Let's say 8 seconds plus, for example, to observe whether we can reach some saturation effects, because initially in the previous slide here, we did not see any saturation. The signal was rising all the time. So if we want to do that, and I've already shown this video, we essentially see that we only get to about 5 seconds afterwards the signals degrade, because we have this phase wrapping and we have this increasing noise because we have all these fluctuations and this moving in the retina. And also, what if we want to go to the inner retina? So if we want to go to the ganglion cell layer, for example, and here we have a video of what happens there. If we look at the phase signals, we have a weaker signal to noise ratio. We might have the idea that there is some X occurring, but it's actually very noisy and we can't get really quantitative information out of that. So, and what we did about that is we just saw the first images after the stimulation. They look really good. So we have a good phase signal for short periods of time. And what we've done so far is we took an initial volume or an average of the initial volumes and compared later time to this initial volume, where only for short times we get good signals. But what we can also do is we can divide our volume, for example, compare our initial phase to the middle phase and then compare the middle phase to the final phase, or we can even divide this further up or use some division that is totally arbitrary. We have 2 short steps, 1 large step, and then following short steps again. And if we do this adding up after we apply the Gaussian filter, we actually get better signals. And I want to visualize this here, where we have for one single data point, one lateral point of our entire OCT images, we have all the possible phase differences one can think of. And what we can do now is we can use the direct phase difference. So that's what we've done so far. And we see that we have, for a short period of time, a good signal, then the signal degrades because we have all this noise here in the upper parts of all these possible phase differences. Is what we call cross spectrum, because it's usually originated in astronomy, where it's an actual spectrum, or it's evaluated in the spectral data. But we can also take our short steps and we see that we get a different phase course. So we have, again, after about 5 seconds, some degrading in the values because we hit a saccade here, which essentially destroys all the phase differences in this diagonal and also in this perpendicular values. So, but if we now use a different step size, or if we make a shorter step somewhere, we can really get good phase differences, and we can do this for all kinds of possible ways through these kinds of phase differences. And what we can do now is we can assign a weight to each of these possible paths through this cross spectrum. And we have these short paths which are less susceptible to statistical changes, because these statistical changes are what is occurring above here. And we have the long paths that are less susceptible to the outliers, for example, by saccades. And now if we have a weight for all these paths, and we now make a fit over all these paths, a weighted fit, where the good paths which have less disturbance are weighted stronger than these with more disturbance, we can actually get very good values. And this is something we published last year in this paper by Hendrik Spar. What does it look like if we use this method to obtain our phase differences? And we can see that we get way clearer information. We still have the volumes where there's saccades. They don't look good, but everything else, we have a fairly nice phase value even over 15 seconds. And we can now also move to the inner retina. Just as a reminder, this has been the signal in the ganglion cell layer, in a plexiform layer, the difference between those 2 layers. And we don't see very good signals. Signals are smaller. We have noise and motion artifacts, and there's also this vascular pulsation that kind of reduces our quality of the signals. But if we use this method, the extended Knox-Thompson method that originated in astronomic imaging, we see that even there we can get really nice phase values, and we see that we get this cross very well, and we can now really assign activity to the ganglion cell layer or inner plexiform layer in between these 2 layers. And what can we do about that? So we in principle, we image these 2 layers, the photoreceptor layer and the ganglion cell layer in a plexiform layer simultaneously. So we can have a look at the displacement between the crosses in the photoreceptor layer and the distorted crosses in the ganglion cell layer in a plexiform layer. And we can draw the outliers and essentially, well, connect the edges. And if we do that, we see the displacement of the response in the photoreceptor layer and the ganglion cell layer and a plexiform layer. And we can now really assign to all these different areas in the retina that we have here what the functional connection between these two layers is. And this really corresponds well to the displacement that was previously found by having a look at ex vivo physiology, anatomy. So can we even do more? Well, we can also have a look at the signals in the ganglion cell layer and the plexiform layer for different intensities. And in the photoreceptors, what happens if we reduce the intensity further, we see that the signals for a long-time stimulation, they begin to deteriorate, they become smaller. And if we do the same thing in the inner retina, we see that the intensity of the response is essentially independent of the stimulation intensity, unless we go to very, very low stimulation intensity. So if we have our original intensity, and which has been in this case 1 microwatt, and we reduce this by an OD of 2.6, we start seeing a difference. But apart from that, we always have the same intensity. And we can also look at this with flickering lights. So we have now the full intensity, we have flickering lights with 50% duty cycles with different frequencies. And for the steady illumination, we see that we have a stronger signal in the photoreceptors, which comes down to reducing the overall stimulation intensity because we only have the 50% duty cycle. If we now look at the ganglion cell layer in the plexiform layer, we see that the signal actually is increasing, which is something that we would expect in the ganglion cell layer compared to the photoreceptor layer. So we have about 2-fold stronger response there, despite the photoreceptors actually seeing less light. And this, well, essentially boils down to the ganglion cell layer response to flickering light. So finally, let's give a little outlook and a summary of what we've done. So the outlook is essentially this: where we want to go is we want to have a functional imaging of the entire retina, and this also includes improving the image quality, maybe getting to images that are comparable to what Don Miller has shown in these ganglion cell images, or what Maciej Wojtkowski has shown earlier today. And we want to improve face evaluation and remove artifacts. And where we are now is that we can see some sort of functional signals in all or in most major retinal layers. For example, these have been the two that we already showed, but we can also go to the inner segment where we see a lot noisier X-shaped pattern, but we see some signal there as well, but the backscattering intensity is so low that this is really noisy. Or we can go to the bipolar cells where we also see a signal. This doesn't work for every image that we have, but for the very best of our images that we acquired, we really see some X-shaped pattern in many different layers. And we can also, again, compare the outlines of these layers, and we see again a slight displacement even between the bipolar cell layer and the ganglion cell layer. So, of course, what we want to find out at some point is what are the limitations of this technique, where can we get? And at some point, of course, we'll have to go to clinical investigations. But as you've seen, the setup is pretty bulky, so it's not really simple to get into the clinics with this setup. So to summarize, we've shown over the last couple of years holographic OCT, which captures the whole wave field, including the amplitude and phase. We can use this to do computational adaptive optics and get comparably large field of views of these cone mosaic over time. And we can use this to actually do functional imaging. So we can have functional imaging of the photoreceptors and also of the ganglion cell layer, inner plexiform layer, both of which very reproducibly by now. Well, we've done lots of investigations on this stuff, and we've also some further results that we're going to show very soon. And finally, I'd like to thank all these people who have been working on this stuff, especially Clara Pfeffler and Henrik Spar, who have been doing much of the actual work, and of course, Jacque Duncan and Jacque Hillmann. Thank you. And if you've got any questions, I will be happy to answer them.
Thanks very much for this very nice talk. There was one hand up for a question during the session. I've promoted that person to be able to speak. if you wanted to make a comment or ask your question. I think it was Jacque Duncan who raised his hand.
Hello, actually, I didn't raise my hand.
Okay.
So,
apologies. Okay. Sure. There was another hand up.
Maybe, I mean, as I have an opportunity to speak, we would be, of course, interested to have some feedback on from the attendants who are more on the clinical side and on the optophotology side. So, because, I mean, we are now working on this technology, so we would really welcome some comments on this, what applications could be.
So would anyone have a comment on that point?
I could just say that I thought the work was lovely, and I think there's lots of clinical applications. Anytime you have objective measurements of visual function and how patients or how any kind of retina is responding to visual stimulus, that can give you a lot of insight into the mechanism of vision loss in patients with mutations that cause photoreceptors not to work well. I'm sure Ram and Austin will have more to say as well, but I think that the work is terrific, and I really think that looking at the other layers is fascinating, not only the photoreceptors, but the bipolar cells and ganglions. I think that's going to be really promising.
Okay, I see there's another couple of questions here. Ram, did you have something you wanted to ask?
Yep, Dierck, that was awesome. Really wonderful talk. I'm just wondering, do you see a difference in time from when the photoreceptors get activated to when the bipolar cells get activated to when the ganglion cells get activated? This could be presumably you could do using your cross-spectrum type approach to see whether there's a temporal delay between these signals. And I'm wondering if you have looked at that.
Well, the thing about if we wanted to observe a temporal difference, we would have some technical difficulties at the moment, actually, because our technique is currently limited to these high-speed cameras. And these high-speed cameras use an onboard memory. So we only can acquire about 8 GB of data. And afterwards, we need to read out the data, reprocess the data, and so on and so forth. So in order to get to sufficiently strong signals to observe them in ganglion cells and bipolar cells, we need to increase the timing between all these volumes. So finally, we only have a time resolution of I don't know, maybe 125 milliseconds. So it's not really that we can really see very small time differences using this current approach. We would need a camera with way more memory and probably also lots of more processing power.
Okay. Well, thanks again for the talk. If there's no more questions, I think we'll move on to our next and final speaker. Austin is going to talk to us about hacking human vision.
Hopefully you can see my slide. Give me some indication.
Good.
Thanks. So I will be talking about something that isn't rendered obsolete by the beautiful work by Dierck Hillmann that he just presented. We still use relatively primitive imaging methods. Point scanning, highly serialized form of imaging, but it does have advantages, and hopefully I will help you appreciate that here. So the title of my talk is Hacking Human Vision, and I will start by explaining briefly what that is. Hacking human vision means stimulating the retina in ways that natural visual processes cannot. And really, it just involves two things. It involves correcting the eye's optics so that we can isolate light and deliver light to individual cones, or nearly isolate it to individual cones, thereby bypassing normal visual processes, which actually involve integrating and comparing signals from multiple cones at a time. And the second thing that we do is control or correct for the eye's motion so that we can bypass normal visual processes that leverage that motion to process spatial information and possibly color information. So in the simplest sense, fundus-guided microperimetry is a form of hacking human vision. By controlling for the motion, we can deliver tests, and sensitivity tests in this case, repeatedly at the same location. If you could not track the motion properly, then that would compromise your ability to delineate and identify regions of the retina that may have deep scotomas. So a consequence to that finding is that the constant motion of the eye, fixational eye motion, actually helps to mitigate vision loss, in a sense that in the presence of absolute scotomas, motion of the eye prevents images landing there from staying there very long. But the remainder of my talk will be focusing on some basic science applications. And fortunately, Wolf described the spatial vision tasks really beautifully, and he described the technology really beautifully, so I don't have to dwell on that. But I will raise the scientific questions, or the phenomena that motivate the scientific questions that we have. And here's one. This is a video recorded where we've actually delivered a 20/18 size stimulus onto foveal cones. And so the subject is looking at a black letter E against a red background. And in most cases, in this case, they would be making a judgment about the orientation of that E. It turns out that humans are really good at this task, and we can do visual acuity even without adaptive optics. Humans can achieve visual acuity levels that are on the order of the Nyquist sampling limit of the mosaic. That alone is surprising. But what's more surprising is that we do that in the presence of this constant motion. We don't perceive this motion, but the motion is actually on the order of and greater than the size of the letter itself, the size of the letter that that person is trying to decipher. And so how is it that we can do this so well in the presence of this motion? And so with the tools that we have, and with all the help from people like Wolf and Kavitha, a student in my lab, Nicholas, Alex, and Bruno, we asked the really simple question: how is acuity perform compared between natural motion, which is the video on your left, versus stabilized condition, which is the video on the right? And Wolf showed that the percentage correct, or your ability to decipher a letter, is better when the image is naturally moving across your retina than if it's stabilized. And all I want to point out is that another thing happens. Many people in this audience might know that another consequence of stabilizing an image is that that image will fade from view. That's also a normal visual process. And we controlled for that by presenting the letter briefly. So this is indeed a reflection of a difference in performance that's solely governed by the motion. And we do better when the image is moving on the retina than when it is not. But I want to step ahead here. And rather than dwelling on spatial vision experiments or microperimetry and threshold experiments, I want to talk about applications where we really pull out all the stops and utilize all the capabilities of the technology that we have. And this is really to study human color vision. And I've been fortunate over the years to have great people working in my lab. These are a few that are actively involved, or were recently actively involved in the color vision experiments that we've done. So again, let me show a phenomena and help you appreciate the profound questions that we have. So this is an image of a human trichromatic mosaic. It happens to be a mosaic of a former postdoc in my lab. And as you can see, The retina is comprised of 3 types of cones, sensitive to reddish, greenish, and bluish wavelengths, or long, middle, and short wavelengths. And they vary tremendously in proportions. The S cones are sparse, and the proportion of the L and M cones can vary anywhere between 1 to 1 and 20 to 1 in the population. But what's more interesting is that given the human visual system's task of trying to resolve spatial information and then attribute to the details that we look at, attribute color to those details, how do we do that with a mosaic that looks like this? How does the brain take information from this array of sensors and make sense of the world and generate the vivid and generally accurate percepts that we have? So using the tracking and delivery capabilities that we have and having a mosaic that was classified, we did this experiment. And it's illustrated in this cartoon. This is not really what we see. But in this experiment, we delivered 543 nanometer flashes of light, chosen because they equally stimulate both the greenish and reddish or M and L cone types. And we would target individual cones in the mosaic. And each time after we flashed light into one of those cones, we asked the subject what they saw. And we gave them 6 options in this initial experiment: red, green, blue, yellow, white, or not seen. And then we repeated the experiment as many times as we could in order to get as many stimulations per each cone in the in that mosaic. And this plot shows the result. So the background image is the cone mosaic of the subject that we tested. And then the pie charts are histograms indicating the responses that the subject made. So for example, this is a condition. This is an M cone where they responded white about 17 times and said green about 3 times. So let me just summarize this result quickly. So even though, just remember, the flash was always the same color. So subjects are colorblind. They can't determine the color properly when they can only use the signal from one cone. And that makes sense because cones themselves don't tell you the color. They just report a certain level of activity. And it's comparing them that allows us to see color. So generally though, when you stimulated an L cone or a red sensitive cone, it mediated sensations of red whenever it mediated a sensation of color at all. Whenever you stimulated an M cone, it mediated a sensation of green when it mediated a sensation of color. Some cones are strong color reporters. Here's one that 20 out of 20 times, or maybe 19 out of 20 times, they saw a vivid sensation of green, whereas the one right beside it rarely elicited a sensation of green. And so there's very distinct variations, but very robust responses of the different cone types. Here's one that always reports white, but right nearby there's an L cone that almost always reports red. So some cones are strong color reporters, whereas other cones are not. And we've followed up on this experiment. Brian did more nuanced or more sophisticated color appearance tests, measuring hue and saturation, and then compared what color appearance might be of individual cones, depending on the background, and then branched out a little more by saying, well, if one cone gives you an incorrect impression of the true color, then what do 2 cones do? And what are the rules for color appearance when you stimulate 2 cones simultaneously? And these are all published in the papers shown here. But it's daunting to think, okay, well, where do we go next? 3 cones, 4 cones. How do we really start to build this picture? So, and as valuable as this type of research is, looking on a cone-sized scale, and we're going to continue to do this, we're taking a parallel approach and sort of looking at this in an entirely different way. Now, this is not your screen going bad, this is my slide. This is what we've been looking at pretty much for 4 hours for the last 3 days. And I just took a screenshot of one of the days. And let's zoom in on Michelle Pack, who's actually looking very professorly there. And depending on the size of your screen, that image, that little thumbnail image in the display that you have for your Zoom video conference could subtend an angle of about 1.5 degrees, and you can use your finger test or your thumb test to confirm. But let's imagine that that portion of Michelle's face was subtending 1.5 degrees. Now let me do a simulation. So what's actually happening when you're looking at that image? Well, I've taken a fake cone mosaic, actually actual locations, fake colors, and I'll just go back a step, go forward. Hopefully this movie will play. And then I've projected it onto the cone mosaic. Based on the color of the image and based on the spectral subtype of the cone that was stimulated, I can generate what's called a cone excitation map. So the white parts excite all the cones equally. The greenish parts excite them, the greenish or less luminous parts excite the cones less. But anyway, the point is that this image lands on this retinal mosaic, generates this complex excitation pattern, and the human immediately and effortlessly and accurately generates a percept based on those signals that looks like the image on the right, right? We're able to see the person, identify the person quite easily and effortlessly. And the more you think about it, the more complicated that process is. So in order to really expand and sort of maybe take a top-down approach where we look at how a human perceives a large scene with thousands and thousands of cones, in fact, millions of cones over the field of even your display, we're lucky to have a team of engineering people at Berkeley, led by Dr. Ren Ng, and a few of his very talented undergrads to help us tackle this problem, because technically it becomes very challenging again, computationally. But to start though, let me step back again and let's go through this thought experiment. So what I'm showing you in the upper left is a red square, and I'm sure all of you see it as a uniform red square. Let's project that onto the retina. I just projected onto a fake retinal mosaic, and we know the spectral sensitivities of the three cone types, so-called L, M, and S. And based on the spectral sensitivities, I can calculate cone excitation map, what listed here is photoreceptor outputs. Now, when the brain is presented with this information, which is just a variation in cone signals, cone activities, what does it do? Does it just immediately attribute it to luminance variations, in which case one might perceive just a modeled luminance variation across the scene that's excited by this red square? Or does it see the red square? And of course, everybody sees the red square, and we do this immediately and effortlessly. Okay, so now let's consider this. Now we have an ability to track the cones. We have an ability to deliver light and deliver microdoses of light to individual cones. And we're going to expand that to as many cones as we can across the mosaic. So now let's take just a second. Truck's driving by. Let's take a stimulus pattern that's not one cone, but every cone in the mosaic. And we're gonna tailor the brightness of that stimulus pattern. We're gonna use 525 nanometer light, which is green. We're gonna modulate the brightness of the pattern patch as per the cone types on the retina that we're stimulating, so that we can generate identical photoreceptor outputs. So this pattern and this uniform red square will generate identical photoreceptor outputs. So the human, there's no choice for the human to make. If we stimulate the same cone mosaic with this pattern, generate these outputs, they ought to see a uniformly colored square. If we can't elicit that type of response, then we're doing it wrong. So what we call this is spatial metamers for color vision, spatial patterns that masquerade as a color signal. Okay, so this is the concept. And so we're actively involved in these experiments, but let me tell you about some preliminary experiments that we did while Brian was still in the lab. So this is a patch of Brian Schmidt's retina, and we could identify and track and deliver light over that entire field of that patch of retina. And in the upper panel here, we've shown a stimulation pattern, again, using only green light, 543 nanometer light, where we're preferentially exciting the M cones or the green sensitive cones in this mosaic. And when we present this luminance variation pattern to this patch of retina, Brian saw a relatively uniform rectangle that was greenish in color. And then we would change the pattern to an L cone weighted. So the dots are in the same place, but now we just beef up the signal going to the L cones and turn down the signal going to the M cones. The light is green, don't forget, but by tailoring the stimulus in this way, Brian saw, again, a uniform rectangle that was colored red. And when we extended the range of L and M cone weights across a spectrum, we could indeed generate a rectangle, uniformly colored rectangle with colors spanning a large range of visual space. So this is definitely an extreme case of hacking human vision, where we can use monochromatic light, pattern it in such a way to generate any type of color response. And extending this further then, and I'm just about done my presentation, but extending this further then, let's consider the video that I showed earlier of Michel Pack. Take his face, project it onto this retina, and these are the cone excitations. So this is where I got in the slide that I shown before. Let me step back, so hopefully it'll play again. Sorry about the videos, they probably don't show that well for you either. But knowing what the desired, or knowing what the cone excitations were, we can tailor microdoses to the cones in that mosaic in a manner that's contingent on what the retina is and how it's moving. And the argument is that if I generate this cone stimulation pattern using 500 nanometer light, then we ought to elicit a percept that to the human looks indistinguishable from the actual image itself. This is, again, I like to show this because I'm super excited about it. This is an example of, extreme example of hacking human vision. We're actually bypassing the entire optical system. We're bypassing any effort that the eye uses to leverage its motion to generate images. We're just going straight to the neurons, not in the brain. Could do that potentially, but it's easier in this case. Directly address the neurons in the retina. Play the photoreceptors in the retina the way we want, and then we can generate any percept. Now, if we fail to generate a percept to our human subject that looks like the original image, if they don't see what looks like the original image, then we've failed to track the retina properly. We failed to calculate the right microdoses properly. We may have failed to classify the cone mosaic properly. So that's the first step. Just be able to recreate a normal visual experience by playing the cells directly, bypassing the optics. But extending on that, we can start to ask very interesting questions. Like, for example, under normal experience, even the greenest green light somewhat excites both the L and the M cones. And that to a human subject, even a monochromatic green light still appears very saturated. But what would happen if I only stimulated the M cones? That's something that natural light and no single wavelength could ever do. It's possible that the subject may see or perceive a saturation of green that they've never ever experienced. In other words, their brain will have to generate an entirely new suite of percepts to attribute to the new sensory signals that come in. That's one example. Another example is that we see color by comparing signals from 3 different cone types. That, in fact, limits the range of colors and the hues that a human can experience. But if we computationally add a 4th cone type, it's possible that we can expand that color space. Now, a human can't even imagine what a new color might be. But if you think about a dichromat, and if you can imagine a dichromat, given a 3rd code class, might be able to see color space like a normal human, a color normal human, then then we just have to extend that argument that if you give a fourth cone class to a color normal human, they may end up appreciating a whole new color space. We have no idea what's going to happen, but we now have the tools to do that. So in summary, bypassing normal visual processes, in other words, hacking human vision, can be used to shed light on mechanisms of basic spatial and color vision. But these new tools also have applications to study, monitor, even treat retinal disease. So, for example, simulating scotoma or cone loss, doing microperimetry, as we heard about, or even fundus-guided retinal surgery. And then finally, need to acknowledge all the people. There's a tremendous amount of engineering that's required. It costs a lot of money, and we need really good scientists to execute clever experiments to do these tests. So thank you, merci. Thanks for sticking it out through the entire meeting. Just want to put in a shameless ad that we're actually hiring people for this, what we call our Oz Vision project. I've heard a lot of talks from really talented students and postdocs from all these labs, and I want you all to come to Berkeley and come and work with us. So thank you.
Thanks, Austin. Any questions for Austin? Serge has one here from the Q&A. He says, you are able to create the impression of color. Can you induce the impression of motion?
Oh, sure. I mean, the type of software that we're in the process of developing will be able to play, we'll be able to track as many cones as we can see within our field of view. And we'll be able to play any microdose to any cone. And so what I showed you in simulation was a simulation of what we would do to generate a static image of Michelle sitting there in the Zoom video conference. But there's nothing preventing us from playing a movie. What we would like to play is we'd like to play Star Wars on the retina through this Oz Vision platform. And so, and then we can compare things like part of hacking human vision is we can start doing micro perturbations of these stimuli to generate sort of artificial motion in the image and see how the visual system behaves to it, or just present natural motion in the image that you would see if you were looking at a video, for example. I hope that answered the question.
Are there any other questions from the audience?
Well, I may have a question.
Okay.
And actually, I mean, since the motion of the retina is very important for the visual process, you would expect that the dynamics also plays a role, what we really perceive. And if I remember correct, there are also some effects that if you have moving objects, black and white objects, that they can appear as a color. So do you think this dynamic processes will be important for hacking, or do you
Absolutely. And I think, you know, the problem, one of the big questions that we have when we look at the trichromatic cone mosaic is that, you know, it's patchy. There's big patches of red and big patches of green cones. And so we are really strong believers that when you allow the eye's retina to slip across an image that you're looking at, that motion not only helps your spatial acuity, but it also informs tremendously, and maybe even more so, about the color of the object. And remember, that cone mosaic has a dual role of informing the brain about color and space. And there's even interesting experiments that Ram Sabason is recently doing, where he gets these types of illusions that you're describing, where what would normally be a colored object starts to appear as just a simple luminance grayscale variation under certain conditions. And he's not fully tested the motion component of that, but we believe it all works together, and it only makes sense. Vision is almost more of a temporal process than it is a spatial. Spatial vision is more of a temporal process than a spatial process.
There's a couple more questions here. Another one came through in the Q&A asking if you stimulate only M cones, what after image color would you expect?
What's after image color? Well, the after image, okay, first of all, stimulating only M cones will generate a level of M cone excitation that even the greenest green, like from a monochromatic laser pointer, could not produce. So that may generate a percept of something that's ultra saturated. If the after image is the sort of the counter to that, so if you adapt to a normal green, your after image might be, what is it, red? Yes. Then it's possible that the after image, after stimulating only M cones, would be a hypersaturated, may have a hypersaturated red appearance. We'll see. These are questions that have never been able to be tackled because nobody's been able to address the cone mosaic in the way that we're proposing to and that we're just actively involved in now.
Okay, one more question here from the chat. Jackie's asking, she says, this has important implications for the treatment of red-green color blindness. Could it also work for patients with cone ops and mutations like in blue cone monochromacy or achromatopsia?
Yeah, now treatment is a bit of a stretch unless your treated subject likes to drag around an adaptive optics system that is the size of a room. So at the moment, we can only generate, we may be able to say, for example, confer trichromacy to a dichromat computationally. They have to sit in the device. We do have an eye toward a future where devices that track and can target stimulate to individual cones in a specific retinal contingent way could potentially be head mounted, but that may not happen in my academic career or maybe in my lifetime. But we do have an eye toward that type of application.
Okay, one last question here through the Q&A just came in. Would it be possible to simulate both dynamic and static acuity?
Yes, absolutely. I'm not entirely sure what we mean by dynamic acuity. That might be a clinical term that I'm not entirely familiar with. So maybe the questioner can clarify, but we can generate any type of pattern on the retina for a visual test with this technology, or we will be able to do that. So if dynamic acuity is maybe a type of a reading task or RSVP type reading task, we could certainly do something like that.
Okay, I had one question. I think I'm just going to ask it. So, you presented, this theory that, you can simulate all these photoreceptor outputs, but the brain's not presented with photoreceptor outputs, right? It's presented with the outputs of the retinal ganglion cells, and many cones are contributing to the center of the retinal ganglion cells in these areas that you're stimulating because it's not in the center of the fovea. So I'm curious to know what your thoughts are about sort of taking and modeling the retinal circuitry, and also, what's your thinking about these, surrounding cones that are contributing to the surround, and whether or not they're tonic activation or there may be some input to those cells that is driving sort of this variability that Ram has showed previously and the percepts for single cone stimulation here. It seems like it gets a lot more complicated than just the photoreceptor outputs.
It is definitely more complicated. The brain has not even close to access to the excitation levels of the photoreceptors. The photoreceptors themselves are tremendously dynamic, and then they get routed through the ganglion cells and processed via all the interretinal circuitry. Still, that being the case, recreating the cone excitations that a natural image would produce ought to produce the same percept. Reproducing the exact neural activity in those cells ought to produce the same percept. We are very interested in the interretinal circuitry and how it shapes the signals from the photoreceptors before reaching the brain. And we've done some work along those lines where we tested the color sensations elicited when we stimulate a single cone as a function of activity of all the cones in the surround. What we aim to do, maybe more so, is generate or ask subjects about what they see when a single cone is stimulated while we're tickling cones in various ways in the periphery. And we're hoping that we can, even if we can't see the circuits, we're hoping that we can sort of reverse engineer what these circuits are doing these types of psychophysics procedure. So that's why we need really talented scientists who can imagine the types of experiments that we could do.
Really, really exciting work, Austin. Looking forward to seeing how this work develops and how you solve all these technical challenges that I'm sure your team is hard at work on. So sorry, Michelle, for the extended questioning there. Michelle Pak is going to now say a few closing remarks.
Okay, thank you very much, Austin. Is my microphone working? Yeah. Thank you, Austin, for making me contribute to your work. It's superb. Maybe I'll be on the publication. Well, I don't know, as a figure, maybe. It'd be great. I authorize you to use my face as a figure for your paper. Okay. So
I'll not only ask permission, but I'll ask for a small payment from you to put that in.
No problem. Okay. So I'm going to share my screen for some closing remarks. So congratulations, everybody, to this to the success of this meeting. So where's it supposed to be? It's not there. Oh, thank you. I'm going to go back. There it is. So thank you to, where is it? PowerPoint there. Okay, so thank you to all the speakers, and thank you for making the effort of being accessible to the largest audience possible. So José Sal, as Kate mentioned, couldn't be there for family reason, and he apologizes. And personally, I'm very happy that replays will be available because many of these talks need a second look at because they're very complex data for me to understand at the first sight was not enough. And a password will be sent to you shortly. It will be available on our website. You already visited, I guess. So what are the next steps? So this, as a reminder, our aim of Kate and me was through this meeting to promote interest for excellence in clinical research, very well illustrated by the last talk. And by exchanges between physicists, biologists, and doctors, and also stimulate new ways of thinking and treating disease for clinicians, because clinicians are not always aware of the tremendous possibilities of retinal imaging, of now functional imaging now. And this is done in a spirit of academic approach rather than industry driven. And we would like to focus as much as possible on human disease because these are the patients that really need our best possible care. And we really believe that the technical progress of the last decade will make the idea that the best disease model is not the animal, necessarily the animal model, but it's the real human disease, in fact. And all this progress is not limited to photoreceptor disease, not even to retinal disease, not even to the eye, because we have nice talks on sickle cell disease by Rosen. We have talk on high blood pressure, on multiple sclerosis. So I think the stakes of high resolution retinal imaging is far beyond the ophthalmology. So in the next years, we hope to expand our transdisciplinary course as well, which seems to have a great success. And we'll also do, in parallel of the meeting, a practical live web session, as we were supposed to do initially in the first version of our meeting. This was canceled because of the epidemic, but we hope to do it by web as a regular meeting. So next year, this meeting will be organized by Ethan Rossi and José Sal. It will be held at UPMC. I don't know yet if it will be on physical presence or by web. And the year after, we'll be back to Paris and so on and so forth. So this will be my last word, and I hope that everybody had a pleasure participating to the meeting and have a safe flight back home.
Thanks, Michelle, and we do look forward to welcoming everyone to Pittsburgh if we can. You know, we'll see how things develop, but really excited to be organizing that, both on behalf of myself and on behalf of Jose. Just say that we're very much looking forward to participation in that, and we'll be reaching out to all of our esteemed colleagues to contribute.
Okay, thanks everybody.
Bye.